Good morning, all. We are all welcome to this week session. We will be starting soon. We are just waiting for to have more people to join. In the next 5 minutes or so, we should be starting. Thank you. Good morning, all. We are once again welcome to this Saturday's edition of the workshop series. And I think our facilitator has joined us, so without wasting time, I will hand over to the facilitator for today to begin the presentation. You are highly welcome, sir, and I think we can start.
Thank you very much.
I think the network is we can't hear you, sir. The network.
I'm grateful for this opportunity. I promise. I hope you are hearing me.
Yeah, we can.
I hope you are hearing me.
Yeah, we can hear now.
It's okay. We will be at interval of about 20-25 minutes. We'll be getting off our seat to stretch ourselves to obey the law of economics so that we don't sit perpetually for this length of time that we are going to be together. But I promise us that it's going to be very explicit, self-explanatory, and immediately after this workshop, we're going to get this particular material for this presentation. I've made this available just about 5 minutes to this presentation to the organizers of this particular training. So you are going to have it that you can still go through it again. So please stay true, please don't log out. Ensure you pick every moment of it. Let me hide my video now as I try to share the material. Good morning, all, once again. I hope you can see my slide. Can we see the slide?
Yes.
It's okay. Thank you. The topic of our workshop today is assessment and physiotherapy management of bronchiectasis. My name is Babatunde Bola Ogudumade. By way of disclosure, I'm the director and head of department, physiotherapy department, Jos University Teaching Hospital, Jos, Nigeria. I equally double as the head of the specialty of critical and cardiopulmonary section of the department. Welcome to the class. So intermittently, I'll be asking us questions. Please feel free to be able to answer, but that will depend on your attentiveness in the class. As you can see from we are in the lecture hall already. Please let's avoid all distractions. Mute yourself. Don't do any side talking. You can get some paper very close to yourself and pen to jot some things down as we go on. As you can see there, I'm standing before you today to talk on bronchiectasis, and that is the picture that you saw there. You get to still understand more about this in the process of time. That is where I'm moving the cursor all around. So every member of the class, you are welcome on board. This will be the synopsis of this lecture today, this workshop. These are the pattern in which we are going to move. But I want to assure us before I go into the synopsis that the intention of this is to pull us from where we are presently high up in the knowledge of assessment and physiotherapy bronchiectasis. So you can be sure that this is sequentially laid down according to this synopsis, going to the objective, the lung and the adjoining structures. We are going to examine it. We are going to look at the lung and what makes it easily susceptible to infection. We'll go into some basic definition, navigating through the causes of this condition, looking at the predisposing factors, the prevalence, how it's developed, different types. We'll equally look at the risks that are involved. And we move on all along there, looking at the diagnosis and tests, examining the physiotherapy intervention specifically because we are physiotherapists, and looking at the possible outcome measures that can be adopted. And this class, even though virtual, is going to throw a practical perspective to this presentation because there will be several case presentations with participatory practical illustrations and discussions among the class. That's why I don't want you to miss any portion of this class this morning. So you are welcome once again. These are the objectives of this workshop. We want to have in-depth teaching on bronchiectasis. We also want to have a detailed teaching on the management of bronchiectasis with intention of understanding and implementing on the field of practice. Likewise, we will focus on the physiotherapy management of bronchiectasis for the purpose of understanding again and implementing same on our field of practice. Then we'll try as much as possible to explore and probe into the scientific world, the rationale behind our physiotherapy intervention, while bringing up case studies for discussions and practical illustrations. And as we tape down on this workshop later in the afternoon, we are going to provide some recommendations on the management of bronchiectasis. This is the long structure, and that's why we are going to be looking at, as we need to lay some foundational basis so that we'll be able to enter sufficiently into what bronchiectasis is all about. So we're going to look at the lung and the adjoining structures. These are the first infographic I'm passing across to you for you to know what we are actually dealing with today. I'm going to explain this very soon onto us. Let's look at the function of the respiratory system. The function of the respiratory system actually include the following. It's not essentially restricted to gas exchange, even though that is what is always known about it. That is true. But we also have function of acid-base balance, phonation, pulmonary defense, and metabolism, and also the handling of bioactive materials. These are the functions that respiratory system carry out from one individual to the other. Looking at the picture of the lung that I showed to us earlier on. Now, the lungs are actually not equal in size. The right lung is shorter because the liver is seated under it. So it has to be positioned in such a way to make room for liver, which is also on the right-hand side. It is tucked under the rib case, but it is broader. So what we have to know about the right lung now is that it's shorter and broader, making room for the liver. And then it also has 3 lobes: apical, middle, basal. Then we have the left lung, which is smaller because it has to give way for the cardiac notch where the heart is situated, and then it has 2 lobes. That is the apical lobe and the basal lobe, even though it has also an adjoining lingula that brings the 2 of them together. So that's the difference between the right and the longer field. And that's why I had to lay this serious foundation to this lecture today, even though we are going to discuss bronchiectasis essentially. Now, when we have the right bronchus, we have the left bronchus, and that's why both of them are called bronchi. And that is like a tree, like we see there now, coming through it, like bifurcating into 2. Now, there's also just like we differentiated between the right lung field and the right lung and the left lung, we're also going to throw some differences between the right bronchus and the left bronchus. The right bronchus is wider, it is shorter and more vertical, just like you see it there. Wider, shorter, and more vertical than the left bronchus. You can see it in the infographic that I'm putting my cursor on. Now, the mean length of it is 1.09 centimeter, and it entered into the root of the right lung, approximately at the level of the 5th thoracic vertebra for your specific landmark area. But when you look at the left lung field, you look at the left bronchus, it is smaller in size when you compare to the right, but longer in length, approximately 5 centimeters. Now, than the right main bronchus. Now, the bronchi actually extend into the lungs. They give they give what do you call it, branches. That is the one we call the bronchioles. They are much smaller and narrower, and those are the ones that enter into the lungs in the different portion of the lung, different bronchopulmonary segment, which I will do today, probably towards the afternoon. So again, the right bronchus is larger in diameter and more vertical, and it has direct line downward into the lung. And that is the reason why you see that when an object is accidentally swallowed, which of course some of us must have heard the story before, we must have read such before, it actually goes directly into the right bronchus. Most, in almost all cases, it is the right bronchus that you see it is going into, not necessarily the left. Now, the basis for these points of differences between the right bronchus and the left bronchus have described to us. Foremost, that the right is wider, shorter, and vertical, 2 to 3 centimeter long. Then the left is narrower, longer, and more horizontal, 5 centimeter long. Now, there are basis. These are the basis for the clinical issues that can be thrown around it. The first one is innate foreign bodies are more likely to enter the right main bronchus. If you are going to ask which of, it's not that I cannot enter the left, but most likely it will go into the right bronchus foremost. Then secondly, the correct placement of a double lumen tracheal tube is more likely to be successful in the bronchial if the bronchial part is inserted into the left main bronchus. So these are the anatomical advantage, peradventure we want to put it in this way, anatomical disadvantage of the placement of the right bronchus and the left bronchus. Now, by way of supply, arterial supply and vein supply to the bronchus, the bronchi are supplied by the bronchial arteries from the aorta. And that's why you see when they talk about pulmonary, even though it's, the specialty may be put as may be separated as pulmonary in some places, respiratory in some places, and also cardiac in some places, but they are a bit interwoven. And the interwovenness of it is what you are seeing in this slide 12. The bronchi are supplied by bronchial arteries from the aorta, and they are drained by the azygos vein on the right and the hemizygous vein on the left. And there's also some drainage via the bronchial and pulmonary veins, which contribute to their physiological shunt. And that's why you see it's called most of cases being called cardiopulmonary. Now, we look at the nerve supply too. And nerve supply is actually autonomic in nature from the pulmonary plexus and the hilum. We have the parasympathetic supply, which causes vasodilation, bronchoconstriction, and increases secretions, and is responsible for the sensation. We also have the sympathetic supply, which vasoconstricts, bronchodilates, and suppresses secretions. So it is the interwoven nature of the action of the parasympathetic and the sympathetic that talks about whether there is going to be more secretion or there will be less secretion. One increases the secretion, that is the parasympathetic supply, then the sympathetic supply suppresses the secretion. Let's look at the alveoli. And the respiratory process as we relate it to the lung air sacs. Are you hearing me, please? Are we hearing me?
Yes, sir.
Okay, thank you. I just wanted to be sure that you are hearing me. Now, the reasons why infections commonly occur in the right lung, let me elucidate further. Apart from what I have told us, let me give us these 6 points. The first one, the anatomy of the lung, as a way of summarizing what I've discussed with us before. One is larger than the other. One has 3 lobes, one has 2 lobes. The one with the right has 3, the one with left has 2 lobes. Then also the blood supply. The greater volume of the blood compared to the left lung gives the advantage to the right lung. Then the position of the R2 is there, which is on the left, close to the left lung field. Then we also have the gravity effect. The left lung field has much clearance when you compare it to the right lung field. Now, because the right lung field goes much deeper. Then we have the anatomical variations too. And then finally, the right lung is more commonly affected than the left because of the usual pattern of the lymphatic drainage within the lung. So let's take these 6 points as the reason why right lung field is easily susceptible to infection more than the left lung field. We move on. Then we look at also foundational. There are special tests that is usually done for the for you in the knowledge of cardiopulmonary metric, which is the process of measuring how much and how quickly air moving and out of the lung. We also have the one called plethysmography, which is known as lung volume test. This actually measures the different volumes of the lung, out the air that moves in and out of the lung. We also have the gas diffusion test, which measures the oxygen that moves into the lung and the bloodstream. And finally, the one that pertains to us so much, the exercise stress test. This test typically involves a bike or treadmill, which of course is essential in any setting that is granted in cardiopulmonary to have. The bike must be there with readable different parameters and the treadmill. This is to actually investigate the exercise, how it affects the lung of the particular individual. Then let's now move to the subject of discussion today, having been able to successfully lay foundation to what respiratory life of an individual is, vis-a-vis the anatomy, the placement of the lung, of the bronchi, its nerve supply, its blood supply, and the role of alveoli, and what makes the right lung field to be easily susceptible to infection more than the other. We go into what bronchiectasis is all about. Actually, bronchiectasis is a condition where the air wall the air wall are damaged. When I started this lecture a few minutes ago, you saw when I put it in front of the class. So damage, it is why
I think your network is not stable. We can't hear you. Your network is shaking.
result of several lung infections. We have mucus clearance. Can you hear me now? Are you hearing me now? Hello, class. Are you hearing me?
Yes, it's okay now. In fact, when you started from the explanation from alveoli, you went off for like, I think 5 minutes or 2 minutes.
Oh, okay. So I should go back there? Should I go back there?
We can continue, sir. I'm just telling the network is somehow.
Thank you. Now, in giving this definition, I'm trying to differentiate between some conditions, chest conditions, that have name close to bronchiectasis or that you probably have come across, and so that you'll be able to know the difference between the two of them. Now, bronchitis and bronchiectasis sounds familiar in pronunciation, it sounds familiar in the name as it's written down, but there's a difference between the two of them. Bronchitis has to do with the inflammation of the large and small airways of the lung. Of course, there could be acute bronchitis and also chronic bronchitis. Now, one resulting from viral infection, that is acute bronchitis, and then the chronic one resulting from smoking and environmental exposure. But the bottom line is that there's permanent widening and scarring in the case of bronchiectasis as compared to this other lung condition, bronchitis. Now, bronchiectasis is derived from the Greek word, two Greek words, bronchos and ectasis. Bronchos means airway, ectasis means widening. There is no way you, after attending this lecture, you will ever forget what bronchiectasis stands for, because it has to do with airway widening. Airway widening. I want you to have that at the back of your mind and also at your left fingertip as we move on. So, having been able to lay that foundation concerning bronchiectasis now, I want to finally define what it's all about. Bronchiectasis is defined as chronic lung condition, which is presented with abnormal, irreversible dilatation of the bronchi, where the elastic and muscular tissue is destroyed by acute and chronic inflammation and infections. That is the broad definition of bronchiectasis. Now, what are the key words? The key words is that it's a chronic lung condition. The another key word is that it is presented with abnormal airway dilatation of the bronchi. It's unnecessarily wider than what I discussed in the anatomy of it at the beginning of this lecture today. And it's destroyed. It's not only that it is irreversible dilatation, it is destroyed. And that's why you see the picture of the lung that I gave in the classroom when we started as a result of infection and reinfection. I want you to look at this infographic, which has to do with the damaged airways impairing the mucus clearance. This again is the two lung feet, the right, the left. Now, this is the normal bronchus. It actually has an inner mucus layer. Normal mucus layer is there, which is to trap offensive organism, foreign organism. It is there ordinarily as the way it is made in its anatomy. And then there's also cilia there. That's why you see what they usually call mucociliary clearance. It traps whatever the offending foreign body that comes in. It's like a net. Let's use that word, like a net. It traps it and then get it to the distal bronchus to be exhaled out here. Now, when there is bronchiectasis on this side of this slide now, where I put my cursor, you see that this what do you call it? The inner mucus layer that I talked about earlier on, it becomes excessive. You can see that it's almost completely obliterated, covered, as if there is not going to be airway passage again. That's what causes retention of the mucus. And not only that it becomes excessive, the cilia that work in conjunction with the mucus, in mucociliary clearance, it becomes damaged. It can't do its work very well. It is like the picture. I always use the picture of broom to explain cilia mucociliary action. Now, when you look at broom stay together, it is not only one stick that make a broom. You have to have many of them. That's why they call it bunch. You have to have many of them. By the time you whip it, as if you want to use it to whip somebody, you will hear a sound. That is like the sound of the mucociliary action. It draws it from one portion to the other until it gets to the distal airway and is expelled out through the process of expectoration. Now, this infographic now is explaining to us how this mucus now that we see in this side, which is normal, is now becoming excessive, and then the cilia is also impaired. And that's why you see now the issue of mucus stays there. It causes infection, it causes reinfection, and then causes abnormal airway dilatation. As you can see it now, see the tissue morphology of this particular broncho. Very fine as it's created. Now, look at this particular one now. It's already distorted, and that is what makes it irreversible, and then a lot of discussion in the physiological action that they carry out. Again, let's look at this normal airway and widened airway. Now, when you look at this is the normal airway. Can you see everything there is cleanly laid down? Now, when you look at the bronchus affected airway, see the distortion again, see the widening. Look at the diameter of this. Look at the diameter of this particular one. It's widened on more than usual. And then see the mucus that are deposited there. And these mucus that are deposited there are also provide invitation to other organisms that can further reinfect, and that's what causes infection and reinfection in the case of bronchiectasis. Again, let me show you this again. Now, look at the normal bronchus again. This will may be clearer unto you. Now, look at the wall of the bronchus. Look at mucus gland again, just like the one I showed it to you. Of the bronchus out by microscope and be able to see it better, maybe for my network to be stable. Are we hearing me now? Are we hearing me now? Hello?
Yes, sir.
It's okay. Thank you very much.
Maybe
Now
you should
look at now the bronchiectasis affected bronchus. Okay. The microtubules, they are lost here. Then see the secretion that is filling everywhere, and also the wall is destroyed. That is what caused a lot of distortion in the tissue morphology of the bronchus in bronchiectasis. Now let's look at the causes of bronchiectasis. Two phases of airway damage are the causes. They go in two phases. The first one is what we call initial damage, of course, which actually happened at the beginning of it all. It is often unknown. It can go undiagnosed in some cases, and about 40% of people with bronchiectasis probably may actually have this because it is the initial infection that takes place, the initial inflammatory disorder that takes place. And this is actually called insult per se. And this first insult actually causes inflammation and repeated infection subsequently. It is when you get to the history that you'll be able to know that sometimes ago, this woman actually had infection before that left undiagnosed, that has now predisposed her to more infection. And that is what leads to the second phase, which is called the vicious circle. So don't forget, first phase, initial damage, called insult, and the second stage, which is called vicious circle, but one lead to the other. Let's try to examine the predisposing conditions. Before we examine the predisposing conditions, it's already 20 minutes. I want you to stretch your hand and leg. Stretch yourself out. Stretch yourself on your seat, your legs and your hands as we prepare to move on. Okay, that's okay. We're going to slide 23, which has to do with predisposing conditions in bronchiectasis. Now, some conditions, when they are already there, makes a patient, an individual, to be more susceptible to bronchiectasis. And those conditions are cystic fibrosis, mycobacterial infections like TB, autoimmune conditions like inflammatory disorders, rheumatoid arthritis, inflammatory bowel disease, then systemic lupus erythematosus, Sjogren's syndrome. They are the likes that are predisposing conditions to bronchiectasis. We also have issues of foreign bodies, tumors, and lymph nodes that can possibly block the airway and prevent mucus clearance. I'm sure you already understood it, the way I explained out the tissue morphology of the bronchus. Then also have conditions that decrease immunity and increase the risk of infection. Conditions like HIV can easily predispose to. Others are pneumonia, heart failure, lung cancer, sarcoidosis, pulmonary fibrosis, then primary ciliary dyskinesia. Of course, this should be expected because of what I've already explained concerning the role of cilia in mucociliary action. Because here now you have ciliary dysfunction in primary ciliary dyskinesia. There are cases of organ transplant, where transplant medication may decrease immunity. It can increase infection and make the patient individual susceptible to bronchiectasis. We also have this uncommon condition. It is called APBA. It is a shortened form of it is aspergillosis, but the full name of it is allergic bronchopulmonary aspergillosis. It's an allergic type of fungus where there is infection and reinfection there, and a lot of investigation has to be done for the patient to be diagnosed to have the aspergillosis. Then there is issue of fibrosis from radiation, and then research also suggests this latest challenge we had in the last few years, from 2020 December precisely, COVID-19 is also has been identified as a common cause of bronchiectasis. But we also have the acute respiratory distress syndrome, which is a linkage, which has linkage to bronchiectasis as a predisposing factors. And we want to look at the most common cause of this now. In US and Western countries, the most common cause is cystic fibrosis. This most common cause actually depends on the location. It varies from clime to clime. So when you examine the presentation, the history people give, you will notice that this will going to differ from place to place. What obtainable in their place will be a bit different from outside now. So in US and Western countries, we have cystic and fibrosis. Then worldwide, tuberculosis will be the most common cause. That is now, I isolated this out of the low log of list I gave as a predisposing factor to bronchiectasis. Then we look at the prevalence of bronchiectasis. Bronchiectasis can actually be developed at any age. I want you to pick that. Even though we are going to highlight some things, but know that it can be developed at any age. But about half of the cases are developed after the age of 65 years, making the geriatric to be easily predisposed to bronchiectasis. The most cases worldwide actually is seen in women. Now, prevalence are not accurately known per se, because the data considerably vary throughout the world. As we see at some data I'm going to throw at us for teaching purpose in this workshop, you will see that the prevalence actually vary throughout the whole world. But areas that are less affluent, communities that are less affluent, have also been shown to be easily predisposed to bronchiectasis, and that probably may be due to the issue of socioeconomic factor. Then also in children, it is known that it is more common in boys than in girls. And therefore, in the United States of America, we have a population of like 350,000 to 500,000 people being affected. And that's about one person out of 150 people who are 75 years or older are actually affected. Then in New Zealand, we have it as 3.7 for every 100,000 of the population. And this also varies according to ethnicity. And in US, according to a study done in year 2005, their own population is a bit more than New Zealand, which is about 4.2 in every 100,000 individual for age group of 18 to 34 years, and 272 for 100,000 individuals, which is who have the age of greater than 75 years of age. And most recently, for a study on an 8-year period, we have a bit of slight increase up to 1,106 people per every 100,000 individual. That is about the year 2012. This fact came out. Then the story is also different in UK, which is consistent to what I told us in the earlier slide, that it varies from clime to clime. In United Kingdom, for a study between 2004 and 2003, we have it, their own is more than that of US and that of New Zealand, where New Zealand is having just 3.7, US is having 4.2 per 100,000. UK was, for men, we are having 486,000. 486 per 100,000, and for women they were having 566 per 100,000. The only thing consistent with the other with the foundation of play concerning prevalence is that it's more common in women than in men. Now, with the highest prevalence in patients that are greater than 60 years of age, that may also still be consistent with the issue we raised, that as somebody, even though it can occur at any age, but as somebody grows older, the occurrence will be more and more. The actual number may be higher since bronchiectasis can be without symptoms. We need to take note that any figure that we see being presented to us today, they are documented one, based on research or probably based on report, but it may possibly be higher based on the phases I told you. I told you that at times it's possible that phase 1 may not be known, and those are unreported cases, so making it the possibility of it to be higher. Then in children, it commonly occurs with cystic fibrosis. about 50 to 75% for the ages of 3 to 5 years, and for the primary ciliary dyskinesia for children for up to about 26% of children. So that means in children, you can have the predisposing factor to be like cystic fibrosis, primary ciliary dyskinesia as a possible cause of it. Now, when we go down to our country, when we come down to our country now, with Nigeria, for a study done in Uyo, South Nigeria, which is a 3-year prospective study of 2016 to 2019, for ages of 15 to 85 years, we have the preponderance of it in male, which is 57.9%, and female 42.1%. And then people presented with chronic productive cough, they are about 94.7%, which of course you begin to think now, which will make us to be relevant as a physiotherapist, as experts in this particular area. If we have patients of 94.7%, having preponderance or presentation of a chronic productive cough, it means that we are going to be so much relevant with our airway clearance technique, expectoration, to get this out so that there will not be infection and reinfection of the bronchus bag. Then we have about 84.2% having at least one episode of exacerbation within the last 12 months. Don't forget, we said that there will be a recurrent of infection. But for this reports, this study that came out, it showed that at least 84.2% of them have one episode within the last 12 months, where HIV accounted for 21.1%, TB accounted for 57.9%, previous TB treatment. This is also consistent with the earlier thing I told us that in other countries, apart from the Western countries, TB could be a major source of bronchiectasis, and that is this study is confirming that now, having 57.9%. Then the cases whereby there is severe exacerbation requiring hospitalization is 47.4%. That also shows us the relevance of us as specialists in this area to come in on board. A referral should begin to come in onto us because since there will be severe exacerbation in almost half of the population requiring hospitalization, we may need to intervene in that instance. Also, there's a high rate of exacerbation with respiratory distress as the strongest predictor of hospitalization. And as respiratory therapists, we also will need to come in the assist. Once there is a high rate of exacerbation, there is accompanied with what do you call respiratory distress. When we move down to Africa, few studies actually have reported a high proportion of children attending respiratory and HIV clinics in Africa who have bronchiectasis. But beyond this, we will look at some scenarios. Associated factor with increased risk in Africa. There's actually increased risk in Africa. The associated factor for it are increased burden of lower respiratory tract infection, severe lower respiratory tract infection. We know that it's a common thing in our climate in Africa that there is a lower respiratory tract infection, of course, which of course includes PTB. We should take note of that. Now, also the second issue is the heavy burden of pediatric HIV infection. With 60% of world children living with HIV residing in sub-Saharan Africa, we have the burden of this disease in our climate. 60% of the children living with HIV reside in sub-Saharan Africa, and we have identified HIV as a possible predisposing factor to bronchiectasis, and most especially in Africa, infection, notably TB, is a noted factor. And then we now begin to see HIV as a causative factor in our climate here. Then lower childhood vaccine coverage too is another issue, apart from the issue of HIV. The childhood vaccine coverage is reduced. We have a lot of factors that affect that. About 79% and 72% of diphtheria, tetanus, toxoid pertussis, that's the DTTP vaccine, and the Haemophilus influenza type B vaccine. They have those 79% and 70% coverage. And then whereby the third dose of the pneumococcal conjugate vaccine has 68%, and only 36% for the second dose of measles vaccine. All these predispose the children in the sub-Saharan Africa to bronchiectasis. Then, of course, this is very obvious, the lower socioeconomic status. Like we notice even in the studies in New Zealand, we see that it differs from climate to climate, and then in some communities. Yeah. So also here, big places we have report of lower socioeconomic status. which makes Africa to be susceptible to it. Then issue of poor access to medical treatment for many reasons, probably also linked to lower socioeconomic status, or probably health centers are not close onto them and they will not be able to report in time. And then also still putting into consideration the first phase that usually go undiagnosed. And then lastly, the lower level of education on identification and management of chronic wet cough and the issue of BTTB in caregivers and medical professionals is an issue. And probably that also underscores the importance of this our workshop now. Not many people know about bronchiectasis. People need to know. If people don't know, the lower level of education on its identification can make it to go undiagnosed. And once it go undiagnosed, it means it's not going to be treated. And once it's not treated, there is a possibility of much infection. We will go into the development of bronchiectasis now. How will it be developed? We're going to look at two. We're going to look at the congenital. We're going to look at the acquired. As the name suggests, congenital is from birth. Acquired is the one that is developed over time. That's why the slide is titled The Development of Bronchiectasis. Now, congenital, it affects infants and children, and it's result from genetic factors which affect the lung form in the fetus as the embryo is coming up. Then the acquired is developed over time. It occurs as a result of another factor, another condition, which I've enumerated earlier on in the previous slide. Now, the acquired affects adults and older children, and it's more common than the congenital type. So don't forget, there's congenital, there's acquired. Congenital in children, as they begin to form as a fetus, the acquired in both children and in older children and adults, and then, but it's more common than the congenital. Now, let us take note of this. The airway blockage can lead to bronchiectasis. That means anything that causes growth or non-cancerous growth, an innate object that is trapped like granite, like a bar, that swallow just maybe aspirated like that. If it stays there and blocks, it can cause blockage of the airway. And once it causes blockage of the airway, it narrows the mucous layer of it, preventing removal of the mucus, aggregation of the mucus, and attracting more infection there. Let's go to types of bronchiectasis. The types, the classification can be done based on two categories. One can be done based on airway damage. One can be done based on the area affected. I want you to take note of these two. The classification can be done based on the airway damage or based on the area affected. Based on the airway damage, we have two types, the cylindrical and tubular type, which is the most common and least serious. Of course, let me first of all discuss this theory. I'm going to give you a lot of infographic that will explain this now, that will make it impossible for you to miss it in the future in case you come across it, or one way, one further or the other, you will not be able to forget it again. Now, the cylindrical and the tubular, know that is the most common, but it's least serious. The other one, based on the airway damage, is called the varicose one, the cystic one, which is the most severe one. It's most severe one because the tissue morphology of the bronchi is destroyed. You are going to see the pictorial form of it very soon. Now, when you look at the second classification of it, is based on the area that is affected. How many areas that is affected? Now, the first one is focal. In that area, it's just like the name suggests, focal is just a section of the lung. The second one is diffuse. Like the name also suggests, diffuse. It goes to many places, in many areas throughout the lung, many sections of one lung or both lungs. And the last one is what they call traction bronchiectasis. This has to do with scarring in lungs, pulling the airways out of shape. And that shows the picture I showed to you when we entered the classroom. When all of us were sitting in the classroom, I showed you a picture on the board. And that picture on the board is a picture of a tissue, a lung tissue that has gone through a lot of scarring over time. And let's look at the difference between the traction versus non-traction bronchiectasis. Now, both of them are the type of bronchiectasis first. The dilatation of the bronchial bronchus due to the elastic tissue and small tissue destruction is what causes the traction of it. It's like when you pull a particular, like a rope, you pull it through a rope, it cannot get back to its shape again. It cannot get back to it. It becomes, there's what we call regional fibrotic changes. Regional fibrotic changes occurs. And when regional fibrotic changes occur, you begin to see this manifesting in this presentation. So there could be traction, there could be non-traction form of bronchiectasis. I want you to take note of that. I want you to stand up and stretch yourself. I want you to stand up and stretch yourself. Are we hearing me?
Yes, we can hear you, sir.
Yeah, so just stretch yourself for a few seconds and we continue. Okay, thank you. You have stretched yourself. We move on. So that has to do with traction and non-traction bronchiectasis. When there's a fibrotic changes, you have the traction one. When there's no fibrotic changes, you have the non-traction one. Now, by way of illustration, for better understanding, look at this morphologic pictorial form of the classification of bronchiectasis. I've told us about cylindrical, I've told us about varicose, I've told us about the cystic. Now, look at the cylindrical one. This is the way it looks like a tree, a branch of a tree you cut off. A stem branch of a tree that you cut off. It has two mouths, and that is the one called cylindrical. Anyone that looks like this on the radiological, which I will still go into details of it, is called cylindrical. This classification is based on the morphology of the bronchi. Now, the second one is varicose one. The varicose one are irregular, and then they become dilated. As you can see, the diameter has increased. The diameter also increased in cylindrical, but it has assumed the shape of cylinder. Now, for varicose one, the dilatation increased, as you can see it now, has increased, then it assumes another shape, varicose shape. Now, it becomes irregular. And finally, we have the cystic type that look like clusters all around. Of course, if you see the graduation of it now, cystic one will be worse than varicose, and then will be worse than cylindrical. So this is a practical illustration of what each of them are. But don't forget, the common part of what is common to all of them is the enlargement. What is common to all of them is enlargement. Is the enlargement of the bronchi. The diameter is widened, is increased, and it makes it not to be able to perform its role very well. Now, let's look at the population of it. Now, the cylindrical one has 45%. The varicose one, 10%. The cystic types has 45%. The multiple types has 25%. That is the presentation of it according to this study. Let me also do another illustration for it now. Look at the normal bronchus as the branches here and there. Look at the cylindrical one. It's already distorted, as you can see. It is widened when you compare the diameter to this diameter of the normal one. Then when you now look at varicose, you see that the diameter is wider and it's more distorted. You can see this disjointed and distorted one. And that's why it cannot do its clearance of the mucus very well. And finally, this is the cystic type. Clusters here and there. And now see how can it be able to perform its mucociliary action effectively for the clearance of the mucus. Is going to be defective. So I don't want you to forget this infographic again. The normal one, the cylindrical one, distortion in the airway. Then the varicose one is distorted more, falling like a weakened balloon. And then the final one, the cystic one, like a completely destroyed balloon. Some of us have seen balloon before that a child has blown over time again, or probably it has affected it. You see the shape is going to assume. That is the cystic form of it. We move on. We look at the risk now of bronchiectasis. Now, higher risks in underlying condition that affects lungs and immune system. That should not be strange to us again. But in the absence of this, the risks increase with age. Two things about the risk. If there's underlying condition, as previously highlighted and as previously thought, it could be a risk. But if we don't have any underlying disease to the lung or to the immune system, the other risk factor will be age. Now, in the past, childhood infection like whooping cough and measles caused many US cases. But because of the vaccine issue is better over there now and antibiotics, this has dropped. Now, nowadays, their cases are only cystic fibrosis, PCD, primary ciliary dyskinesia, and some other conditions that weaken the system. In their adults, the disorders can be the risk can increase with issues like COPD, asthma, esophageal reflux disease, rheumatoid arthritis, and inflammatory bowel disease. Then chronic pulmonary aspiration too could make them to be susceptible to be a chronic tissue disease. We want to examine the symptoms now of bronchiectasis. What are the symptoms? What are we going to see? We should begin to take the previous slides we have taken should be exhaustive enough to guide us on what to ask for when we are tracking, when we are listening to taking history of patients that are affected with this condition or presented with this condition. We move into another dimension of this workshop now, which has to do with symptoms of it. We need to know the symptom is going to be presented with, because these are the things we are going to examine in the process of examining the patient presented with bronchiectasis. One is daily cough that occurs over at least 8 weeks. Over at least 8 weeks. Of course, I've been able to differentiate earlier on strategically. I've been able, when I was giving definition, I've been able to differentiate between bronchiectasis and bronchitis so that we don't mix it together. When you look at these coughs that occurs over at least 8 weeks, somebody may want to say it's a bit close to chronic bronchitis. Well, it may be close, but that one is for chronic bronchitis, it has to be cough 2 successive months in 2 successive years. So it makes that difference in the issue of the 8 weeks. So it cannot be bronchiectasis in that instance for 2 successive years. So now we look at there's also daily production of large amount of sputum with lots of mucus, which are strapping particle and pus, which of course should not be different to us, should not be different to us now, because we already understand the reason why mucus accumulates. So they have to produce but most especially if the cough reflex is not impaired, and is also in conditions where, in cases whereby they are already on treatment, and in conditions whereby they have been taught some procedure that can bring it. And then the issue of repeated colds, bad smelling mucus, dyspnea, shortness of breath is there, wheezing that actually increases with flare up. This is wheezing. I want you to listen to me. That is it, just like classical whistling. You put the whistle of the referee in your mouth and begin to blow. That's the way it's going to whistle. Picked up by auscultation, or in some classical cases where that is so much, you may even don't need to auscultate before you know that there's a whistling in this particular patient. So it's when there's flare up, you have it there. There could be chest pain, there could be hemoptysis, and then there will be nail clubbing, which is swollen finger tips for the individual with cough nails. Other symptoms include which may happen over time include frequent respiratory infections, tiredness, fatigue for the person. That is if it has become prolonged, fever or chills with chronic inflammation and infection. Of course, you expect that with the issue of infection and reinfection, then shortness of breath, night sweat, and then progressive loss of weight, particularly in children, and possible slow growth for them. Let's explore the pathophysiology now of this bronchiectasis. The airway and the bronchi that extend into the lung, I've told us before, have mucus defense, which is for protective purpose. I'm not talking in terms of the pathology whereby it becomes excessive. I'm talking about the way it is formed, the way it is situated, and the way it performs its physiological action. It has those mucus. But when it becomes excessive, that's why we have this disease condition. Then when there is inability to cover this mucus, it causes lasting damage to the airway. Then when we breathe in, any particle that comes in is trapped by the mucus. I've explained that to us. Then the airway clearance, the cilia, help to coordinate in a fashion in which it is taken out. And that is like when you see the wave of the sea. Let me give this analogy. You see the wave of the sea. Some of us have been by the seaside before, or we have watched the film before that will show how the waves of the sea move. It carries debris from somewhere and come and put it by the seashore. And that's exactly what mucociliary clearance does. It clears it from where it locates it from and serially get it across to the distal airway and it's caused out of the mouth. So that's the process of it. So in ciliary damage, the mucus are trapped. There's a build-up of it. Bacteria comes in there. They find a convenient house. They begin to multiply themselves. There will be infection upon infection, which result in damage and worsen bronchiectasis and cause possible complications. Now, these are the way in which diagnosis can be made. These are the diagnosis and tests in bronchiectasis. And this is the way we go about it. We'll do the history taking, which must be consistent with what I have laid down since we started this workshop this morning. We do the auscultation for the patient, putting a stethoscope to the chest to look at the different buccopulmonary segment, which I'm going to still explain to us. Then we look at the imaging test, which in normal instances that will be the HRCT. I'm going to show that to us in detail, how we can identify it by the time we meet imaging test on the field. That is the high resolution computed tomography. They look at the chest X-ray, we look at the sputum cultures. With deep coughing, we can produce the sputum out for some analysis there. Of course, in instances whereby there's impaired expectoration, the patient may have to go through nebulized treatment, which of course we are relevant as physiotherapists through the electronic nebulizer. It may be with bronchodilator, it may not be with the bronchodilator, depending on whether there's vasoconstriction or there's a bronchoconstriction or there's no bronchoconstriction. When there's no bronchoconstriction, you just do it with steaming. It's like conventional steaming. The aim of it is to soften the mucus so that it can easily be produced out for examination. And that's one primary relevance of physiotherapists in the management of respiratory conditions. We may be called upon not only for treatment alone, for laboratory investigations or research investigation into the content of the sputum of a particular individual. May I say this patient is finding it difficult to produce sputum. The purpose of referral is for production of sputum for investigation in the lab. That's one way in which a referral can actually come onto us. Then blood tests, which will detect the underlying condition that lead to the bronchiectasis. Of course, in this condition, you expect that the white blood cell, the infection-fighting blood cell, is going to increase if there is an infection. Then there is issue of lung function test, which detect the extent of the lung damage, taking into consideration the air that is breathing or breathed out, how fast it is done, and how the lung is able to maneuver it around the body easily. Then, of course, you know about issue of gene susceptibility that I talked about earlier on. Genetic testing is done to detect the genetic condition that causes a person to be disposable to bronchiectasis. There's this also what they call sweat chloride test, whereby sweat is taken from the arm or leg sample for signs of possible CF, cystic fibrosis, and finally bronchoscopy. And what bronchoscopy is all about is that a non-flexible tube called bronchoscope is taking it has light and camera, is to find out what is causing the blockage there, and also to possibly bring out the mucus or possibly bring out the source of the blockage for further analysis in the laboratory. And I want us to take note of this. The chest CT scan is a key test for diagnosing bronchiectasis. As I will explain to us very soon, it's a key test that has to be done. That when you examine it, it will show to you which one is cylindrical. It will show to you which one is cystic. It will show to you which one has become so fibrotic there, because it's very, very specific, because it provides some fine detail where and the location of the airway, where the lung is being irritated, where it has become damaged. So it's essential for the diagnosis of CT, for the diagnosis of bronchiectasis. Now, I want to give some illustrations now on the radio diagnostics that is going to help us on how we can, when we get to our field, when we come in contact with bronchiectasis condition, we'll be able to see it on radiogram. I pause here to ask whether we are still on the line. Are we together? Are we together? It's okay. Thank you very much. So we go into the radio diagnostic illustrations now. This is the X-ray here we see now. We see the dilatation of the bronchus. Now, this is different from the TB one where you see different strands. It's different. This one is as a result of dilatation of the bronchus. Of course, here we see is the two lungs that are affected, but more on the right than the left. That has to do with the X-ray. But don't forget, I said that the ICT is the most, what do you call it? Is the most specific diagnostic test that has to be done. Another X-ray now shown here now, which has to do with the cystic fibrotic here. Can you see the pockets of it all around? Here, the right lung field is affected. The dilatation is there, the right lung field, and the left lung field. But look at what the right arrow says, the fat arrow. The fat arrow talks about the tram tracking, which I'm going to explain to us very soon. Then the thin arrow, it shows about the right upper lobe collapse. Right upper lobe here is collapsed. Then the thick arrow here, it shows the ring shadow, rings here and there. And these are the different types of it that I'm going to explain to us very soon. Now, this is for the, of course, it's an elderly person. I told us it's more common in elderly person as a risk factor. Now, this elderly person is presented with dual condition of a chronic obstructive pulmonary disease as well as a bronchiectasis. Now, again, the arrow shows tram tracking appearance of dilated lower lobe. See it now. It goes together. You see the way the tracking is done in the illustration I'm going to give to us here now for better understanding. Now, this is more explicit to us because you can see the mucus plugging all around here. Mucus is plugged around, trapped inside the bronchus. And that's what the arrow is pointing out in all this. And then, of course, you see now that there's a lot of cystic changes in the lung field here, talking about the middle lobe, the anteromedial aspect of the middle lobe and the lower lobe of the right lung field, and a bit of the medial aspect of the lingular area of the left lung field. Then we move on now to the issue of the CT scan. Now, I want you to look at, there are different things they call them. There's in the illustration in CT scan, that's what they call signet ring sign. Signet ring sign. Now, if you see where this arrow is pointing to, I hope we are seeing my cursor. It's like a signet sign, like a ring. We know no ring, we have ring in our hands, we keep ring in our hand. We see the way ring is a circular structure like this. I think you can see it here. This is where my cursor is. Let me remove the cursor and you can see it under my cursor. Here. Okay, I put my cursor now under it. This is ring. This is what they call signet ring sign. And that's where the blue arrow is pointing.
Since your network is down, we can't hear you again, sir.
In CT scan, signet ring sign. This go to another. Okay,
sir, you went off.
Your network
is bad. It's back now.
It's back now. Please, where did you miss so that
when you are describing the ring from the signet from when you are describing, that's the last thing we had.
It's okay. It's okay. It's okay. That's slide 53. I'm still there. Now let me go back again there. Now look at my cursor. I said, you know the shape of a ring, even though this is not as big as a ring. We are just using it to a cyclical something. You look at this very well. Where that arrow is pointed, you see many of them all around. Small circles all around. That is what they call signet ring sign. Signet ring sign. Signet ring sign. I hope we can see it. Can we see it, class?
Yes, sir.
Okay, that's it. You will not miss it because I told you that ACT is very, very specific. When the film is out, we see, but you are need to have this knowledge so that you know what to look for and what you are going to pick from it. That is what they call signet ring sign. Now we also move on. Still in the end, now this one is clearer now. Can you see this one, slide 54?
Yes,
Can you
sir.
see
We
this
can
slide
see.
54? Can you see the
Yes,
rings all
sir.
around?
Yes, sir.
Yes, sir. We can see it.
Yes,
Yes,
that
sir.
is signet ring sign. So we move on because that one is clearer. Now we go to another one, which is a cylindrical or tubular bronchiectasis. Okay. I want you to call it
Your
either
network
by
is good.
area. Okay, let me hold on. Are we hearing me now?
Yes, we heard when you said cylindrical.
Okay, yes, that's where I am now, slide 55. Don't forget the classification I gave earlier on. I said it's either due to the damage it has done or the extent or the area that is affected. Those are the things that the CT scan is going to show to you because it's very specific. Now look at this one, is cylindrical and tubular, like a tube. Can we see it all around? Can we see the way I put my cursor? Yes, that is cylindrical. Can you see that it's different? It's different from the one I showed to you earlier on, isn't it?
Yes, sir.
It's okay. Thank you. Now we move on. Let me go to slide 56. Now, here we go to varicose one. Varicose one, bronchiectasis. Can you see a distorted tube here, where the blue arrow is pointed and where my cursor is? Can we see it? This is normal. This is not a normal shape of a tube. Can you see it?
Yes, sir.
It's okay. Okay, the network again. Let me hold on for a few seconds, whether the network can come back. Hello? Are we together now?
Sir.
Yes, sir, we are together.
It's okay, fine now. Now, I'll show you the signet ring, which I know you'll be able to identify now. I'll show you the cylindrical one, which I know you'll be able to identify now. I'm showing you varicose now. See, it's just like a varicose vein. The inside is distorted. Can you look at it very well where my cursor is and where the arrow is pointing to? Can you pick that? Hello,
yes,
can we pick that?
We can see it. We can see
yes,
it.
Sir. Thank you. So I leave
yes,
that one now. Now we now see this another one. Now this is a young individual. This one already have a cystic fibrosis. It has a different. You can pick different tastes for you. It has ring. It has ring. It has tubular. It has what do you call it? It has a cylindrical. That is there. Can you see all of them there around? This is ring. Can you see the ring, the signet ring? Can you see the tubular?
Yes, sir.
Can you see the distorted profile too here?
Yes, sir.
Yes, sir. It's okay. Thank you. Now, so these are the illustration I have for you, so that when you pick the CT scan, apart from the, of course, the truth is that there will be report accompanying it. But beyond the report accompanying it, you yourself will be able to see it that this is actually what is happening here. Now, look at this one again too here now. These are signet ring that are here. Signet ring here. These are tubular that are here. So you will see all this when the patient is presented with such. Of course, this particular one too is giving you the same illustration. Now, let me now begin to gradually break them down one after the other, even though I've laid some foundation. Now, these are the signs that will be seen on the lung CT. The first one, you remember I said tram track sign. They are ticking not parallel lines of the cylindrical wall. You see lines coming up like this, as if you mark line to your room or line to your office. The signet and that one are typical of a cylindrical bronchiectasis, the tram track. Those lines, they are typical of cylindrical bronchiectasis. Now, when you go to signet one, which is like the same size of a ring, like I told us, it shows dilatation in bronchiectasis. Now, there's another one they call signs of Pierce signs, string of Pierce signs. This one shows a fluid-filled bronchus which is typical of a varicose vein. Look at the distorted balloon that I told you about. Then the last one is what we call like a bunch of grapes, like clusters. You know when they say clusters, some things gather together like that, gather together. It's just like, let me give a illustration closer to it. It's like when somebody put sputum on the floor, all around each other, cluster together, multiple together. Those are and you will see each of them now. I'm going to demonstrate to you. There's tram track sign, there's signet ring sign, there's pear sign, there's also bunch of grape. The bunch of grape again is how to do with clusters of grapes like that. Now this is track sign, like lines. And that's what you see now. This red arrow is pointing to. Can you see these lines? As if somebody drew line in the lung. Can you see the lines? Can you see lines?
Yes, sir.
Yes,
This
sir.
is what they call track tram lines. It's typical of cylindrical bronchiectasis. Typical of, and this is the radial X-ray presentation of it. You see lines all around, and that is cylindrical form of bronchiectasis on a radiology for its diagnosis. Now we go to signet. Like I told you, this is why this is put on this like ring. It's like a ring that you put on your hand. And you see now, all those illustrations I gave to you earlier on, I've now been able to enlarge it out in this particular slide for easy identification for you. You see the way the ring is appearing now, it's enlarged, as if we put it under microscope, beyond what I showed to you in a slide that looked like this the other time. Can you see the rings? Where my cursor is? Can we see the ring?
Yes, sir. Yes, sir.
Signet ring. And this is also a signet ring, but as a result of pulmonary tuberculosis. All around, rings all around there, scattered there, as if we drop ring inside the lung. So we move on. We move to the bunch of grapes. Don't forget, I told you that it's like when I gave the illustration of somebody put sputum down on the floor, together, very close to each other. Or when you buy grapes, some of us have bought grapes before. We know what grapes look like. When you buy grape, they stick together. They are small, they could be big. They cluster together. And when they cluster together, that's what we call bunch of grapes. And that one, you see it in cystic fibrosis. Can you see clusters here? Can you see where my cursor is? Can you see?
Sir. Yes, sir.
This is cluster. This is bunch of grapes. We use bunch of grapes to illustrate it, to drive home the point so that you will not be able to forget. Don't forget, track tram is the one with lines. Signet ring is the one with signet, like a signet ring. Then bunch of grapes is the one that looks like clusters together. And that's what you see in what? Cystic fibrosis. See this as if somebody is wearing socks. This is too long. It looks like somebody is wearing socks, isn't it? Isn't it? Can you see this? As if somebody is wearing black socks, isn't it? Hello, are you seeing it?
Yes, sir.
It's okay. Now, can you see the clusters? Where my cursor is
Yes,
going?
sir.
Clusters.
Yes, sir.
Here and there. Both right and left. Clusters. Some of us who have done research, you know what they call about when they have cluster of people. Can we see the clusters here now all around? So I know you will not miss it. It's like a bunch of grapes. Clusters together there. And when this now happens, what do you see? That's what we need to diagnose. This is what I now put on that picture in the classroom when we came in. Can you see the fine lung, what it has become? Can we see it?
Yes, sir. Cystic
Is it the
fibrosis.
same lung, you know?
No.
Some of us are asking, is it the same lung, you know?
No, sir.
It doesn't even look like something inside the chest of a human being, isn't it?
Yes, sir.
Now, the question I'm going to ask you is, this is actually making you to know what bronchiectasis can do to a particular individual. And that's why we call it a gross pathology of a bronchiectatic lung. Now, what do you think will happen to an individual? I want you to look now, beyond now. We are going to continue in this class. But let me make us to be provocative in thought a bit. What do you think? You can unmute yourself and talk now. The next 5 minutes we'll talk. What do you think will happen to an individual presented with this type of lung now? Unmute and talk.
Well, there's plenty space in the lung. So because there's plenty space, we expect that something will fill it up like fluid. So the person will likely choke because they're having a lot of fluid in their lungs.
So I think this kind of the presentation, if there is a patient like this, the person should be living on life support.
Thank you. More comments? More comments?
So the person will likely have a lot of infection also and
Thank
poor
you.
lung expansion.
It's okay. Thank you. Thank you. One more person before we move on and stretch our leg before we come back to class.
Person might have reduced lungs volume.
Reduce lung volume. Thank you very much. One more person. Class, we must talk.
The person will easily get tired.
Easily tired. Easy fatigability. That's what we call easy fatigability. It's a term that any physiotherapist that is into cardiopulmonary will know that term. Easy fatigability. And it's something that should attract the interest of physiotherapists. Go on. Go on.
Poor sleep. Person cannot sleep because person will be unable to sleep.
Yeah, the person will not be able to sleep. You are right. You are right. You are right. Two more people.
Definitely, the person will be able to exchange gases and there will be more trapping of carbon dioxide.
Thank you so much. So, respiratory acidosis.
Yes.
And confusion.
Confusion, yes.
Yeah.
Thank you.
Headaches.
So, let's stretch our leg. Somebody still want to talk? Talk before we go on.
I said headaches, sir, because of the
obstruction of F.
Yes, I
If you
agree
still
with
want
the
to
person
talk
under
before we go
32.
on, it's okay. Thank you.
I agree with the
Stretch your
person
leg.
under 32. The airflow will be ineffective.
Yes, it will be ineffective. Thank you so much. Thank you. Now stretch your leg. Stretch your leg. We'll come back to class in the next 2 minutes at 11:25. Stretch your leg. We'll come back to class at 11:25. Stretch your leg. A minute more for us to come back to class. Make sure you stretch very well. I'm sure you have a bottle of water too close to you. You are welcome back to class. As part of the diagnostics, there's something. Are we back in the class? Are we back in the class?
Yes, sir, we are back.
Are we seeing my slide?
Yes, sir.
Which slide number am I on? Which slide number am I on?
65. 65.
It's okay. You are flowing. Thank you so much. Thank you so much because you are flowing. Now, as part of the diagnosis, I've gone through the radio diagnosis. I still want to talk about another one, which is called increased bronchoarterial ratio. This has to do with the diameter of the bronchus, which usually measure approximately 0.65 to 1.0 times that of the adjacent bronchopulmonary artery. Now, between 1 to 1.5 is still considered normal in individuals that are living at high altitude. But once it's greater than 1.5, it indicates bronchiectasis. So once you see that report, you know that this is a sign that bronchiectasis will take is actually happening. Once again, this has to do with bronchoarterial ratio. Usually 0.65 to 1.1 to 1. When people are living in high altitude, it's expected that you increase. It will be between 1 to 1.5. But once it's greater than 1.5, it's a sign of bronchiectasis. Now, there's a number of ancillary findings too that can be recognized. Of course, some of them now will not be straightforward. You know, we are going to the issue of test and diagnosis. But because we have been able to successfully done some underground foundational issues about etiology, the tissue morphology, the destruction of the tissue morphology, some of the things we are bringing up now will not be strange to us, we will easily understand it. Now, a number of ancillary findings can be recognized, like bronchial wall thickening. This should not be strange to us. It will be thickening. The normal wall of bronchus should be less than half the width of accompanying bronchoarterial branch. But there will be thickening in this instance. There will be mucus impassion. There will be ear trapping, and there will be bronchoarterial enlargement, like I explained unto us. So we move on. What are the possible complications? With all that has been said, the complications that I'm going to teach on now should also not be strange to us. When there is severe presentation of bronchiectasis, of course, the one that has already gone to vicious circle, they will lead to serious health conditions. There will be respiratory failure. There will be pneumothorax heart failure. There will be emphysema. No, let me pause here. That's why, again, you see the term being said cardiopulmonary. You may wish to separate, you may wish to leave it like that. You have not done anything wrong. Because one can lead to the other. Respiratory to cardio, cardio to respiratory, even though they can also stand separately. We see complications that bronchiectasis now is throwing up. Respiratory failure, pneumothorax heart failure, emphysema, lung abscess, collection of pus in the pleural cavity, atelectasis, whereby there is collapse of the lung, either one portion or the whole lung is collapsed, which leads to shortness of breath, increased heart rate, increased respiratory rate, and possible cyanosis. These are complications that are seen in bronchiectasis. How can we prevent bronchiectasis? From what I've said, particularly on the issue of epidemiology, with particular reference to Africa, sub-Saharan Africa, these preventive measures will also not be strange to us. The preventive measures are childhood vaccines. I told us that one of the reasons why we may have high preponderance of it is the percentage of vaccination utilization in Africa, which I told you put at 72 to 78 in some DPPT vaccines. Now, one of the ways to prevent vaccine is measles and whooping cough. And this is one campaign we can lead as physiotherapists. This one campaign we can be effectively involved as physiotherapists, as experts in this area. Because once we do this, we have successfully helped our population in preventing bronchiectasis, particularly the one that is in childhood presentation. And we have prevention of pneumonia, influenza, COVID-19 vaccines to lower chance of lung infections. Very, very important. Then the protection of the lung through the issue of avoidance of toxic fumes, gases, smoke, and other harmful substances. Of course, protection of our children. Anyway, we know they are involved in a lot of things. So for some of us that are into cardiopulmonary, into pediatric physiotherapy, you may need to learn this year now. The protection of our children in their home environment should be part of the package of our intervention. For them, educating our parents, and also for some of us that are also of childbearing age, you rear children, you don't put any of these objects close to the vicinity of the children. Whether you are with them, you are not with them. You may not be looking at them. They quickly pick it. And then those are I told us about the issue of granite. I told us, coin is no longer all that's seen in our population again now. But in those days that are coin, you know what happens. But we have things like ring. We have things like the cover of biro. We have things like the cover of a swan water bottle. Those things should not be within the reach of children because they are harmful substances that can affect the children once it's taken in. Then, issue of treating lung infection in children, pneumonia has to be well treated so that they cannot be to be able to preserve the lung function and prevent damage and susceptibility to bronchiectasis. And then, also, we must just be alert with our children when they are doing toys, when they are playing with toys. Don't forget again, people in pediatrics, sit your patient's children, parents down or their keeper down. When they go home, clear your home or your sitting room with toys that can easily be ingested by them. And then look after your caregivers at home. Instruct them on the same thing too. When you do this, you help to prevent bronchiectasis. On this note, I'll be going into an aspect that is more practical to us now that we have to do on the field, the management of bronchiectasis. Are we together, house?
So I have a question. Do I wait till the
Okay,
end?
go ahead. Go ahead.
So when you talked about the small objects, I was thinking for a child that has a condition like chronic cystic fibrosis, if the
Yes.
child inhales something like say granite or toy, and we say we want to do something like Heimlich maneuver, is there any risk that there are other complications we'll be considering too?
Before you
That
do
is, if
maneuver,
we
I would suggest that investigation be carried out. Where is that trapped in?
okay, so in that situation, even if the child inhales that object, because I would feel like somebody that
Don't
thinks
forget
they
what I
know
told you. We must
first
be able to
aid.
locate where it is. It's more likely going to the right. Yes.
Yes, sir.
So I would not want us to rush into that. A debate
Okay.
was thrown about that some months ago where I was about it. The first thing is to locate where that thing is before you do any maneuvering. I would suggest so.
Okay, I see. Thank you, sir.
Yes. And of course, that has to do with bronchoscopy, like I explained to us earlier on. That's why I took time to explain each of those procedures to us, at least for the portion that will be relevant to us on our field. Thank you for that question. Please feel free at any time in the course of this presentation. If there is question, feel free to ask me. We'll go on. We'll go to management of bronchiectasis. We're going to go in triangle, like a tripod stand. We're going to go into medical treatment, go into surgical treatment, we're going to physiotherapy treatment. Now, medical treatment, of course, medications will be involved. When I go into the next slide, I will explain much of the medications that will be involved that we are going to use. Now, it's very important to maximize treatment response. We know the knowledge of the type of medication, the route of administration, the time of administration, and the duration of the peak of the efficacy of the drug. Now, when we go into the surgical treatment, as I'm explaining the surgical treatment, I'm going to tell us some of those drugs that we are going to encounter. So I don't want to repeat it. That's why I leave it that way for now. In surgical treatment, the aim of our treatment is to excise the diseased lung. All of us, we have come into agreement now, based on the slides we've taken so far in this workshop, that the lung is diseased, isn't it? Now, the portion that is diseased, based on the investigative test that has been done, is now excised wherever possible. Then another aim of surgical treatment is to preserve as much healthy the lung parenchyma as possible. Preservation is there. The third one is to increase the quality of life or people, the one that has already having debilitating condition despite their medical treatment. Of course, you don't go into surgical treatment until it is proven that there's a failed medical intervention there. That means, there is no much response, not failed, let me not use the word fail now. When there's no much response, appreciable response to medical treatment, surgical treatment may be inevitable. Then also, it is aimed at preventing complications like empyema, hemoptysis, and bronchiectasis. Now, the anatomic localization of disease must be clearly marked out by the radiologic and angiographic investigations before this can actually go into effect. Now, what are the considerations for surgical treatment? Surgical treatment is usually considered in any of these conditions. I want you to take note. The symptoms have persisted instead of repeated courses of medical treatment. And these are the medical treatment I told you that will be done. I said I deliberately left in the first slide there. Antibiotics is part of the medical treatment. Mucolytics has to do with something that can soften the mucus. The drugs that soften the mucus, that makes you to bring them, because if it's soft, if it's not soft, if it's thick, it will be adhered to the bronchus. It will be different. That's why you see somebody is coughing. That's why they say productive cough, unproductive cough. Somebody can cough and may not be able to produce that if the mucus is so thick. So mucolytics is softens it and make sure it can easily be brought out. It's a softening mucus that can easily be brought out by the mucociliary action or by cough. Then bronchodilator in case there's a bronchoconstriction or steroid, and then chest restraping. When all this fail, so when all this did not work sufficiently for the patient, then a surgical treatment may be inevitable. Then when there's unsuccessful medical treatment, which of course happens in 47.8%, that is substantial, isn't it? Then when there's hemoptysis, which happens in 31.9%, and then where there is a case of non-diagnostic lung mass, which is in 13%, and then where there is lung abscess, 7.3%. All these are indications or things that are taken into consideration for surgical treatment. Then, of course, other indications may be frequent hospitalization on account of the condition. Then, other considerations of failure of medical treatment. If the sputum production persists after 2 to 3 cycles of treatment, that is a failure of the medical treatment. Even though I told you I don't want to use that, and it means that it's not actually being, what it means is that it's not because there is no intervention, it's because there is no substantial response, positive response to the treatment, like 2 to 3 courses of our treatment. Then when there's permanently damaged areas of bronchiectasis, when they have poor antibiotic therapy response, then you begin to look for surgical treatment. Then when bronchiectasis is associated with lung abscess, surgery may be delayed.
Your network is bad. We only had
with antibiotic.
your network is bad, sir.
I will stay here. Network is unstable. Let me wait for a second. Hello, is network back?
Yes.
It's okay. Now, immediate indications for surgery in the presence of lung abscess include increased abscess size. If the abscess size is increasing, there's indication. When there's unceasing infection, there's indication. When there's contralateral contamination, there's an indication. Now, recurrent or massive hemoptysis for more than 600 ml of blood within 24 hours will indicate surgery. Then, early surgical treatment is indicated to avoid life-threatening reoccurrence of hemoptysis. When there's life-threatening reoccurrence of hemoptysis, decision may be made along this instant. And also in children, indication for surgery are the same as in adults. We need to take note of this for our colleagues that are into pediatrics. Now, evaluation is done to ascertain receptability of the lung tissue, the aspect that is affected. Now, these are the procedures that are carried out. I want you to take note of it. Let it have behind your fingertips. It will come under the aspect of diagnosis, refining diagnosis to you. Segmentomy, whereby a segment is removed. I told you I'm going to still talk about BPS very soon. Bronchopulmonary segment. Now, segmentomy has to do with 4.3%. Lobectomy has to do with removal a lobe. I told you right lung has 3 lobes, left lung has 2 lobes. Now, in 65.2% of cases are like that. Then there could be combined segmentomy and lobectomy, whereby a segment is removed and a lobe is removed. That is about 4.3%. There could also be bilobectomy, whereby 2 lobes is removed, accounts for about 11.6%. Then there could be pneumonectomy. That has to be with surgical removal of the entire lung, which accounts for about 14.5%. So your referral diagnosis may come in any of these 5 forms. Take note of it and know what each of them means. Segmentomy, a segment. Lobectomy, a lobe. Like segmentomy can be in combination with lobectomy. Then it could be bilobectomy, 2 lobes. Then it can be pneumonectomy, the whole lung is removed. Then resection of damaged lung tissue is preferred instead of removing high volume of tissue. I want you to take note of that. And that's why investigation precedes intervention. This surgical intervention is when all those investigations I told us about is done, and results come and say, oh, this is particular portion of the lung that is affected. This is this pulmonary segment that is affected. It's the pulmonary segment of the apical lobe that is affected. Okay, that is the one that will be removed. There's no reason removing the whole lung. It's a portion of it that is actually removed. And these are the indications for surgical treatment. I use just like infographic to explain it. Severe or frequent exacerbation, treatment of complications, localized lesions, when there's tumor, when there's recurrent refractory or massive hemoptysis, when there's failure of medical treatment, like I told us, there will be indication for surgical treatment. Now, what are the necessary investigations as we go ahead with the examination now? You know, we are under treatment now. The first one is perioperative bronchography, or IRCT, the high resolution computed tomography, which I know you are advanced in it now, because you can identify the ring, you can identify the tract arm, you can also identify the grapes, the clusters of grapes. Now, this will show to us the type. It will show to us whether it's cylindrical, whether it's cystic. You are going to know. It shows the intensity. It shows the distribution of it. Then the pulmonary function tests are done, which will estimate the lung function in distances. Of course, with the disease lung picture I showed to you, all of us talked and we agreed that the lung will not be able to be as functional as it used to be. That means the pulmonary function test, the indices will drop. It will show that it's not optimal. Then bronchoscopy will rule out the issue of bronchial obstruction. I've explained that already. The stenosis, the narrowing of it because something is blocking it. Then the chest tube drainage may be necessary post-operatively. Of course, there may be need for post-operative radiologic investigations that we need to look at. Now, the possible post-operative complications are post-operative pneumonia, atelectasis, respiratory
We can't hear you, sir.
it is possible to go from this state to Ross. If you look at all of them now, it looks that network is unstable. Let me wait. Are we together?
Yes, sir.
It's okay. Which slide am I? Which slide am I?
81.
Okay, thank you so much. That means we are together. I'm asking this so that we know. I want to ascertain that we are together and I'm not ahead of you. Now, we are on post-operative complications. And if you examine this slide very well, I want to leave about 1-2 minutes for us to examine this slide very well. You tell me which one is most possible to be a complication. Which one?
Wound infection.
Okay, thank you very much. Wound infection, that's good. Which one is the third one that can be most possible complication?
Lung leak.
Okay, thank you so much. Which one is the least possible complication?
Contralateral pneumothorax.
It's okay. Thank you so much. That means we are moving, isn't it? So we move on. Let me go to 82. 82. Postoperative complications again. Now, where is it possible to have more complication between right and left lung field in pneumonectomy? Hello, are we together? Are we together?
Yes. Yes,
So
sir.
in pneumonectomy, which one is more going to be affected? Left or right lung field?
Right.
Thank you. So do we agree so?
Right.
It's okay. Thank you. Now let's go to lobectomy. Which lung field, which lobe is more susceptible to complication?
Left lower lobe.
Thank you very much. Left lower lobe. Thank you very much. Now let's go to bilobectomy, which has to be with two lungs. Which one is most susceptible to complication?
The inferior lobe. Left lower
Inferior.
lobe and middle lobe.
Yes, sir.
Inferior. That's right lower lobe plus middle lobe, isn't it?
I'm not saying
Yes.
Can you see that slide 82? Can you see the slide 82?
Yes, sir.
It's okay, fine. Now, let me go back a bit. In lobectomy, which one is least susceptible to complication?
I can't
Network. Is your network back? Is your network back?
The network is good.
Okay, is it stable now?
Yes, sir.
It's okay now. Let me go back a bit. Still on slide 82. In lobectomy, which one is least susceptible to complication?
left upper lobe.
Left upper lobe.
Thank you. Left upper lobe. So we move on. So let's go on. Now, when we look at we want to look at complete recession now and incomplete recession. We want to look at the results. Now, the results are rated as excellent, good, and no change or worse. I want to ask you, what is the rate of success in a complete recession? What's the rate of success?
84.7.
Complete recession.
That means the viable option to go, isn't it? Isn't it?
Yes, sir.
Yes.
Yes, you got it. I'm just buttressing that. That means a viable option to do what? To go into, isn't it?
Yes, sir.
Okay, now
Yes, sir.
that's why I noted, according to this study by Pireto et al., there is the evidence suggests that the surgical treatment plays an important role in the clinical and symptomatic improvement of patients with bronchiectasis because it actually reduces the mobility and the mortality rate with careful pre-operative operation and appropriately selected cases. And of course, you know through now that we are relevant. Once this is done, we come in as a physiotherapist. Now, still talking about complete recession versus incomplete recession. Now, complete recession resulted in significantly better clinical outcome than incomplete recession. You can see it there now. And also, a meta-analysis by Fan et al. In 2015 concluded that long recession in the management of non-cystic fibrotic bronchiectasis is associated with significant improvement in symptoms, low risk of mortality, and acceptable mobility. And that's why you see that our relevance will continue to be there. Because we come in preoperatively, we come in postoperatively, the surgeon will give us referral, we come in, we collaboratively work as part of the team that is going to manage this condition. There's good prospect post-surgically. Now, most affected lung in bronchiectasis, I have talked about that. Let me skip that a bit. And let's look at pre- and postoperative spirometric values. What can you see in these values that I'm throwing to us? I want to make slide 86 participatory discussion for us. What can you see in this slide I'm throwing to us now? to count of pre and post-operative spirometry values. I want you to talk.
It's about, the FEV is about the same. But
thank you. No significant difference, isn't it?
Yes, sir. The FEV one. Yeah.
Fine. Fine. Is everybody seeing it?
Yes,
Is
sir.
everybody seeing it?
Yes, sir. We are seeing it.
It's okay.
Yes, sir.
Now, I want you to look at the reason. You are right. You are right. No significant difference between pre and post. Now, despite the pericardial recession, we are not saying this that the position is not good, is good. I've already established that. But we are just trying to tell us values. What values mean? Now, the respiratory functions are not altered meaningfully, certainly because of the little contribution of the resected lung to the pulmonary ventilation. It doesn't mean that the process has not worked. It has worked. But that section that is removed is not significant enough in the collaborative functioning to it. That is the reason why you see that value that is shown to us in that slide. I move on to post-operative follow-up. At follow-up, 91.7% patients were found to have improved in their clinical condition, which also shows the efficacy of intervention. 1.7% reported worsening in symptoms after surgery, which still shows that it's significantly, what do you call it, successful, isn't it?
Yes, sir.
Okay. Now, 6.7% showed no symptomatic improvement. Now, mean follow-up in literature is 2 to 6 years. Now, I want to, when I discuss values, I don't just discuss values or throw figures. I want to talk about the implication of values and the implication of figures.
Wow.
If there's mean follow-up in literature 2 to 6 years, what does that suggest to us? I don't want to talk yet. What does that suggest to you?
Well, one of the risk factors you mentioned earlier was having more than one exacerbation in 1 year. So for
Okay.
2 to 6 years to have no issues, it looks like a good number.
Okay, fine. You got it? Further, let's talk more. There's still something I'm looking for. Okay. Now, are we together in the class? Are we together?
Yes, sir.
It's okay. Now, let me tell us the implication of this now. We will continue to be relevant. Let me highlight this. You see that letter with my cursor? Will continue to be relevant throughout these 2 to 6 years, isn't it?
Sir.
Yes.
Yes.
Yes, sir.
I want you to look at the context of your practice now. Vis-a-vis the patient that is presented with this condition, it means that if there is follow-up for 2 to 3 years, as established in literature, physiotherapy too is also going to be part of it. Isn't it true?
Yes, sir. Yes, sir. Yes,
So
sir.
you are not looking at just the immediate post-operative. I hope we are together, class.
Yeah, together.
Yes, thank you so much. So we leave that now. So other key points on surgical treatment are these. Surgery success usually is related to the extension of the disease. We agree on that. The underlying cause, the completeness of the recession, the risk of mortality in bilateral bronchiectasis, and patients with bilateral bronchiectasis need to undergo a complete cardiologic evaluation for possible intrinsic abnormalities before operation. Once there is the issue of a bilateral affectation of in a bronchiectasis, which is a possibility I've told us earlier on, even though it's a bit rare, then the patient will need further examination, cardiologic evaluation before undergoing the procedure. Then also the presence of reduced disease area has the potential to draw symptoms. If the area that is affected is not much, it has potential of dropping symptoms. Then we look at mortality rate in adults. The pooled mortality rate in adults is 1.5%. The pool mobility is 16.7%, and the pool proportion free of symptom after surgery is 66.5%. Is that not also significant, isn't it? Free of symptoms, 66.5%, isn't it?
Yeah.
It's okay. Now, no clinical improvement, 9.1%. We move on to slide 19. Now, post-operative mortality rate in children. Our colleagues in pediatrics, you take note of this. Now, post-operative mortality in children. Mortality rate in children is 2.8%. Morbidity rate is 17.6%. While asymptomatic after surgery is 64.7%. Good result for the children, isn't it? Isn't it, our colleagues?
Yes.
Yes, sir. Yes, sir.
Yes, so we move on. So we have good news for the children. We now move on to our domain. We spend so much. We spend 90 slides out of this 184 slide presentation on laying some key foundations. The remaining 94 slides has to be with physiotherapy, our core domain. And this is what we are going to do. At this point, you stretch your leg, you stand from your table. I should be back in class at 12 o'clock. I give us 4 minutes for this. Thank you. Get set, stretch yourself. We'll be back in class at 12 o'clock. We have 4 minutes break. Thank you.
Not
Sorry, network cut me off. I'm back 2 minutes later than planned. Are we together? Are we together?
Yes, sir.
Okay, I'm sorry once again, network cut me off. I'm back 3 minutes later than planned. We plan to come back at 12, but I'm coming back now at 12:03. I'm sorry for that. So which slide I am showing to you now?
91.
Okay, thank you so much. So we start from slide 91. We go all the way to 12:30. At 12:30, we stretch our leg again. Now, we look at physiotherapy management of bronchiectasis. And we start with the taking of this history, the medical history of the patient. We look at the history of childhood infection, childhood respiratory symptoms. Let me flip us back a bit. I've told us about the congenital and the acquired. That is the reason behind it. And that's why you see, once you get your history very well, but someone said that 60 to 70% of diagnosis of patients they come from history. That's why I want you to get your history well concerning taking of history of patient. It's very important before you go into the diagnostic test. If I am going to guide you, it's going to guide you into the next step you are going to take concerning the patient. And it's also cost-saving measures for the patient because you are already guided. You already know what you are looking for, and then you begin to ask patient to go do that. It's going to be a lot of what do you call it? Cost effective in the management of the patient. Now, the family history of bronchiectasis, you look at it, especially the issue of cystic fibrosis, smoking history, presence of symptoms that may suggest systemic inflammatory disorders. Now we begin to talk about things that make people to be susceptible to and make you to begin to think along that line. The duration of the complaint the patient is giving unto you, the individual is giving unto you, the severity of the symptom, you look at it, the frequency of the infective exacerbation, you want to take note of it, how frequent. That will also guide you what you are looking at. Is it acute? Is it in the initial phase or the one we call insult, or it has got into the cycle phase of it? Then you look at the signs of infection, which may include increased amount of sputum, the thicker sputum, the more difficult to clear, the color sputum, the temperature of the patient, the chest pain, the coughing, whether there is blood or not. Don't forget to tell you that there's a possibility of hemoptysis here too. So these are the details that you look at. You take that will direct the direction of the questions that you are going to ask the patient presenting before you. Then from the history taking, we move on to the objective examination. Then in the objective examination, you do peripheral examination, signs of chronic lung disease, you look at it, the finger clubbing, that is the indentation of the finger. Nail bed. Then you look at the cough, you look at the quality of the cough, the strength of the cough, the frequency of the cough. You look at the sputum production. Of course, you first of all term the cough, whether it's productive or non-productive. Productive means it is bringing out sputum. Non-productive means it's not bringing out sputum. Then the sputum that comes out, you look at the quantity of the production. It's very important. Of course, this can actually be weighed over time too. It's a sort of outcome measure. Reducing quantity beyond the issue of impairment of production of sputum may also be signs of good prognosis and the patient is improving if there is no impairment of the ciliary action. Then the color of it, you want to look at it. Of course, the one that is stained, maybe infection and real infection. The turbidity of it has to do with the thickness of it. I told you the reason why mucolytics is used at times is when they are suspected that thick mucus, thick sputum, then it may take action, prescription to be able to soften it so that it can easily be brought up. Then you do your auscultation. We do to look. You know, I told you the possibility of ways which I've demonstrated to Rob, which I can demonstrate the presence of crepitations, crackles, things that do like, or when you put your hand on your ear. This is especially for male people can, and if you have any for female, if you have any male close to you, you can put your hand on the hair close to your hair. The kind of sound you hear with rubbing of that hair on the head is represent what crepitation looks like. And then wheezing is typical of sound, like I explained to Ross earlier on, demonstrated. I can do that again. You see it. I told you in classical one, without auscultation, you will hear. In the one that is not so classical, you put your stethoscope on it, and then you on the chest, on the different buccopulmonary segment, and then you'll be able to pick the wheeze out. Then dyspnea, which may be on exertion, which is experienced by 3 out of every 4 patients, is a strong possibility. That means any little they do, they begin to breathe heavily. Then stress in part of the objective examination, I have to put in, because possibility of excessive coughing resulting in it. You may begin to wonder, why do you have to put incontinence in part of the examination of this patient? It's part of the thing that determine their quality of life. And it has to do with repeated cough. Issue of cough, 2 things that can result from cough. There could be what they call tussive syncope. Tussive syncope has to do with like fainting as a sort of repeated cough, particularly when it's not productive. Patient is just with labor breathing coughing. There's also the issue of stress incontinence associated with it, dripping of urine from the genitals. So you also examine incontinence. These are scientifically backed up. I'm going to throw up some literature to us in the course of our subsequent slide to us. But let's take note that we need to look at it in our objective examination. See, part of objective examination, exacerbation, possibly several times in a year, identified by 4 or more of these signs or symptoms: change in tone, increased dyspnea, increased cough, fever greater than 38 degrees Celsius, then increased wheeze, decreased exercise tolerance, fatigue, lethargy, radiographic sign of new infection. All those ones shows issue of exacerbation in objective examination. The presence of pain, that could be musculoskeletal complications, pain locations in the neck, chest, middle, lower back, due to coughing and compensatory postures. These are the musculoskeletal complications that can come up for the patient because of the position they adopt, position of comfort. They have some compensatory posture, they begin to develop some complications along. And then also because of, if there is labor breathing and the process of coughing and all, they recruit accessory muscles of respiration. Then those muscles can get fatigue in the process of time, and they begin to ache too. That's the reason why we need to turn on to examine this aspect. Then poor posture, poor malalignment, scoliosis, and kyphosis is a possibility. And the parameters that are needed to be monitored are respiratory rate, body temperature, thoracic excursion, arterial circulation, cyanosis, which is a sign of desaturation in the patient, reduced SpO2, heart rate, blood pressure, ECG monitoring has to be done, and in patient with cardiac dysfunction or lower arterial oxygen tension, particularly during exercise, we need to do ECG monitoring may need to be done. The assessment of breathlessness using a modified version of Ball scale of passive exertion is also part of the thing that need to be done with different parameters, whether in terms of the equipment or in terms of paper assessment. Now, also ambulatory oxygen assessment. And the treatment of physiotherapy. Our treatment as physiotherapists are the following. Are we together? Are we together?
Yes, sir.
Are we together? Are we together,
Yes, sir.
class?
Yes, we are together, sir.
Which slide are we?
95.
Oh, thank you so much. Thank you so much. So we move on. We are trying to look at the aim of our physiotherapy intervention. And these are the aims: controlling and alleviating symptoms like dyspnea, exercise tolerance, reducing the incidence of acute exacerbations, 3, preventing disease progression, 4, reducing airway obstruction, 5, relieving cough, 6, enhancing mucus and secretion clearance through mucociliary transport, Then finally, reducing the work of breathing. These are the aim of treatment, and of course, improving the quality of life of the patient, the individual involved. Then other aims are optimizing alveolar ventilation, optimizing lung volumes and capacities and flow rates, optimizing physical endurance and exercise capacity, then managing fatigue induced by ineffective clearance and increased coughing. I told you that coughing can throw up fatigue for the individual. Then we also have optimizing general muscle strength and peripheral oxygen extraction, reducing the incidence of exacerbation, and eliminating microorganisms from the lower respiratory tract. Of course, once the sputum expectoration is encouraged, you reduce the incidence of reinfection because the microorganisms are removed. And of course, finally, just like I said at the end of slide 95, improve the health-related quality of life of the patient. How do we go about these aims as physiotherapists? Now, intensive preoperative chest physiotherapy is necessary to obtain acceptable decrease of the daily volume of sputum. Don't forget, I did say earlier on that it's not only for treatment, it may be for investigative purpose, may be required to get the sputum out for laboratory analysis. But for treatment purpose, yes, preoperatively, chest physiotherapy protocols come in. And chest physiotherapy, including postural drainage, at least 2 weeks prior to the surgery. Very important. Our referral may come in handy, and 2 to 3 weeks before the surgery, begin to do our intervention here. And then we continue until the daily sputum is less than 50 ml. Then preoperative postural drainage is essential to clean the intratracheal secretions. You know, that's very important because you go into surgery, you need the trachea to be well potent for the patient. So also to decrease the sputum volume, sputum accumulation, and hence to control the infection. Very important. Then we need to take note that more than 70% of bronchiectasis patients expect to raise sputum daily with high variable sputum volume. Don't let us ever forget that. 70% of them, they do daily expectoration of sputum in different volumes. And our treatment must aim to prevent mucostasis and the associated mucus plugging, airflow obstruction, and progressive lung damage. Of course, once you prevent mucostasis, once mucus plugging is prevented, once airflow obstruction is prevented, then the patient is at a better pole position to prevent progressive lung damage. Of course, Snyder et al. 2015 has already done that, given us that evidence in literature. And we have the airway clearance techniques to do this. When the review of the high resolution computed tomography findings that I taught us earlier on is done, to determine the result comes out, it will help us to determine the appropriateness of postural drainage in the relevant bronchopulmonary segment, because we know that postural drainage has to do with the bronchopulmonary segment affectation. I'm going to teach us that too in subsequent slides with adequate pictorial infographics for us to be able to pick it, and how we can practically get that done on our different fields wherever we are located, whether it's a sophisticated field with all the gadgets or the one that is not a sophisticated field that is in rural area, how we can be able to get that done for our patient. I will show us in subsequent slides. Then gravity-assisted positioning, where it is not contraindicated, is recommended to enhance the effectiveness of our airway clearance technique. Of course, that has to do with our postural drainage. Now, the airway clearance techniques are actually customized and modified as required, particularly during acute exacerbation. Even though they are standard rules, standard position, but you need to look at the peculiarities of your client, of your patient, of the individual affected with bronchiectasis to be able to do the repackage that he or she needs. You do modification as necessary. Of course, that is also as documented in the literature. Then, broad categories of techniques include positional options, which I'm going to talk about. The approaches are modified to accommodate comorbidities as necessary. We have established we have successfully established that there may be, and in almost some good instances, comorbidities. So the intervention we are packaging for the individual will take into consideration, will accommodate the comorbidities that may be necessary for that individual. We are not going to overlook. It is not right to overlook the comorbidities that are present in that patient. Now, this is the active circle of breathing technique. This is what it's all about. There's 3 to 5 deep breathing, there's breathing control, there's 3 to 5 deep breaths, then there's 1 to 2 offs, and there's breathing control. And by the time the patient goes through all this, you see the patient becoming calm, the patient will effortlessly be able to bring out the sputum, and then you see the respiratory rate of that patient dropping down. The next 3-4 slides will show some picture of something that you can really practicalize. The paused lip breathing, that is breathing in through the nose and counting 1 to 2, breathing out. Breathing in through the nose, you can practice that on your own now. Breathe in through the nose. Are you breathing in? Are we there?
Yes, sir.
Hello?
Yes, sir.
Okay, breathe in through the nose. Count 1, 2. Then breathe out through your lips. Your lips together. Bring it out. Small, small. 1, 2, 3, 4. Has somebody gotten that done?
Yes, sir.
Yes, sir.
Okay. Keep practicing that for 1 minute now. Keep practicing that to gain mastery of that. You can look at your slide in front of you. Practice that to gain mastery of it. Practice that to gain mastery of it. Good. I'm sure you can get that done, isn't it?
Yes,
Can
sir.
you get that done?
Yes, sir.
Are we together?
Are we together? Yes, sir.
It's okay. Okay, sorry. I think I jumped one. Okay. Now, this is coordinated breathing. Breathing through your nose. Try and breathe in through your nose. Then you breathe out as you do movement. Probably you just move your hand up and down. That's a coordinated breathing. Can we get that done now? Have you been able to do that? Are we together?
Yes, sir.
Which slide are we?
102.
Which slide are we?
102.
It's okay, thank you. So I move on to the off cough. You're taking a slight deeper breath than usual through your mouth. Practice that now. A slightly deeper breath than usual through your mouth. Now, I want you to contract your stomach muscle now and blow the air out in 3 breaths. I want you to actually practice this and gain mastery of it. Deeper breath than usual through your mouth. I'm doing mine too. I've taken a deeper breath than usual through my mouth. My stomach muscles are contracting now, and I blow the air out in 3 breaths. Through that, you successfully empty your lung, and you can provoke cough, bringing out the sputum. Practice that once again. Good. Have you gained mastery of that now?
Yes, sir.
Oh, thank you so much. Thank you for following. Very nice class. Now, let's look at this deep breathing approach. The first one, step 1. Of course, you are seated now, but you can also do it in standing. If you are sitting, your hands be on your lap. If you are standing, your elbows be behind you. Then you take a deep breath through your nose. Then you breathe and count to 3, then exhale.
So is this a longer inhalation, sir?
Yes. You first of all breathe in through your nose. You inhale. But because this is based on the process, the process of respiration is diffusion. It's what you take in that is going to determine what is going to go out. So once you do that inspiration, deep one, then you now hold that breath for a split of a second, and you count 1 to 3, then exhale. Exhalation. Has somebody gotten that done? Has somebody gotten that done?
Yes, sir.
Okay, thank you. So we move on. So let's look at the physiological rationale of the airway clearance technique. We are scientists, so we want to show the necessity of science in our intervention because it's beyond the procedure. So the augmentation of sputum clearance via a number of mechanisms. That's what this airway clearance technique is all about. There's improvement in collateral ventilation and independence. There's increase in expiratory airflow velocity. There's reduction in airway resistance. There's use of gravity. There are changes in airway pressure and generation of airway oscillations. And 58% of adults with bronchiectasis regularly actually use airway clearance technique, while 89% of clinicians use it during an acute exacerbation. It's a procedure of ours that is worldwide accepted, that goes on. Technology improving or no, this is a technique that is always with us. I want you to master it. And these are the basis for its use. It's beyond just a procedure. It has scientific basis. There's increase in expiratory airflow velocity. And even through that now, there is a force that is generated to propel mucus out of its base, to be expectorated out. Of course, because of also its reduction in the airway resistance, the amount of force required for the work of breathing will be reduced. And because of the associated effect of the gravity, it drops the effect of the effort that will be reduced, that will be used, and that the patient will not labor so much. Then short-time improvement in sputum exploration with the use of airway clearance technique has also been reported when compared with no treatment. So showing its efficacy, and also its similar effect on the health-related quality of living sputum exploration, lung volume, when compared to other clinical procedure in stable patients have also been well documented. So it's a procedure that is scientifically backed. Now, adherence to airway clearance techniques is actually critical. It's one thing for prescription. It's another thing for adherence. The adherence I'm talking about now has to do with the patient doing it on his own as you have recommended as own program, or even when he comes, doing it for him or her in your facility or the facility of intervention. Now, adults is that talking about the issue of adherence now to procedure, to this prescription. Adults with bronchiectasis have 41% adherence rate, a bit less than half of the population. There's likelihood of more adherence in those with better physical function, greater burden of treatment, and more severe respiratory symptoms because they know they need it, so they will do more. Now, predictor of compliance to treatment, to airway clearance technique, are older age, because of course, it's affected in them. The issue of the fact that they know they need it more, they will do. And also a strong belief in the necessity of the procedure will make people to do more. That's why patient education is very, very important. You need to convince your patient before this intervention is done, probably at the point of assessment. You need to convince him or her that this is a procedure that is inevitable, but that is inevitably productive in the management of the procedure. The way you sell it out to the patient is the way he's going to buy it, and it's what is going to make the patient to believe. And when the patient believes in it, there will be compliance rates, adherence rate will improve. So patients with bronchiectasis may be at risk of non-adherence. Patients that will be at the risk of non-adherence are the people that are younger. They have concerns about their medication. They do not think airway clearance techniques is necessary, age factor. Not yet. What are they talking about? What is even this all about? Is it not just I stop there. I want the moderator to come on board so that we possibly may have about 15 minutes break. Moderator, please come so that we have 15 minutes break. Thank you. Are we together? Are we together?
Yes, sir.
Okay, let me just hang the class to 1:45. I want you to go and do whatever you want to do, whether you want to visit toilet, whether you need to get a cup of water that is not close to you, whether you want to put a little food. I give us that liberty of 15 minutes. 1:45 will be back. Thank you. Are we together?
Yes, sir.
So 1:45 will be back in class. Thank you very much. Hello, class. Hello, class. We are back. Are you back? Are we back, class?
Yes, sir.
Okay. Thank you. I hope you are able to take some little water.
Yes, sir.
It's okay. Thank you. You are welcome back. Now, where did we stop? Where did we stop? As a way of recap. Two people
So
to
we just
talk.
finished talking about airway clearance techniques.
Okay. That's good.
And
Another person? We talk about adherence issue, isn't it?
yes, sir.
So what did we say about adherence?
We say it's more likely to happen for people who have a higher burden of disease and who have more affectation of the disease. They're the ones that are more likely to be adherent to intervention, and it looks the adherence rate is like less than half, 41%.
Okay. That's a good one. That's a good one. Thank you. So, and how does that apply to us?
Okay.
I think you said that the importance of that's what makes education very important to people. That if we educate them to let them build on their belief of the importance of airway clearance techniques, it will increase the chances of compliance.
Thank you very much. Somebody else want to talk? It's okay. I did that to ascertain that we have followed up to slide 107. So from there, we move on. At this point now, we move on to BPS. BPS has to do with the bronchopulmonary segments. And the relevance of this and the strategic positioning of it in this workshop is this. It's very important in our airway clearance techniques that we would adopt, because this is what is going to determine which of those procedures we are going to pick. One. Secondly, it's strategically positioned at this point in time in the workshop, because that is about the thing we are discussing now. So the placement and the discussion is strategic. So when we talk about BPS, shortening form is bronchopulmonary segment. And we are discussing it so that we'll be able to understand it for the purpose of drainage and sputum clearance. Bronchopulmonary segment, each one is actually a discrete anatomical and functional unit. Very important, we need to understand it. And it's also relevant in the surgical intervention that we have discussed before. This discrete anatomical and functionally located structure now means that it can be surgically removed without affection of others. That's the importance of it. That's the clinical relevance of it. Relevance in clinical management, relevance in auscultation, relevance in airway clearance techniques. Those three relevance we must not forget. Distinctly located, distinctly functional, relevance in anatomy, structure delivery, functional delivery, relevance in surgical intervention, relevance in auscultation, relevance in our physiotherapy intervention. As such, how many are they? Don't forget the rule 32544. You know, we are used to abbreviation that make us to remember things. 32544. Now, what does 32544 means? It means I told us lung has three lobes. Upper lobe has three segments. apical posterior
You're breaking up, sir. You're still
anterior.
breaking up, sir.
Middle has two segments, lateral and medial. Lower, put your hand on your right lung. That's 3, 2, 5. Then, now, on the left lung, there are 4 segments each. That's what I call 4, 4. But you may see it in some instances. Some people say 5. Because the last 4 is, it may be true that fused together in some instances. That's why some people say 5. But in some cases, most cases, they will see it as 4. So I pick it as 4. So right lung, 3, 2, 5. Left lung, 4, 4. So that makes it like 18 segments. 10 on the right, 10 on the left. Of course, you know, we have talked about the structural differences of right lung field and left lung field in the earlier part of this presentation today. We laid some foundations, but we need to dissect further for purpose of clinical relevance. That's why we have to do this. So don't forget 3, 2, 5, 4, 4. So we move on. And these are infographic illustration of those segments I told you. Here is the lung field where my cursor is. The apical is this, having 3. 1, 2, 3. This is middle, having 2. 1, 2. This is basal, having 1, 2, 3, 4, 5 segments. And when you go to the right, left lung field, you have for the left, for the apical, and this is the basal one. 1, 2, 3, 4, and that is the structure. We have the apical, we have the posterior, we have the anterior for the apical lobe, and for the middle lobe, you have the medial, you have the lateral. For the basal lobe, the right basal lobe, you have the superior segment, you have the posterior segment, anterior segment, oblique segment, and the horizontal fissures. So, and you can now see from this infographic I've given you how the segmentomy is visible. Can you see this portion can easily go up? I hope we are seeing it. Hello, I hope we are seeing where my cursor is.
Yes, sir.
Okay,
Yes,
that is the clinical surgical intervention I was telling you about. This is another portion. So depending on what the test says, the aspect of it that is maybe damaged, according to the result of the test, is going to determine that surgical intervention. This is the relevance of buccopulmonary segments in terms of intervention. Also in terms of auscultation, when you put your stethoscope, it's not just putting stethoscope one place for the patient. You say you have listened to the lung sound. You listen throughout the lung field for the lung sound. That is what's going to tell you which is the, permit me to use this word, the offending buccopulmonary segment that need to be attended to. Apical, posterior, anterior, and then middle, lateral for the middle lobe. And that's how you do your auscultation. So that goes on like that. So from there now, it launches to postural drainage position based on the buccopulmonary segment. Now, for apical segment of both upper lobe, this is where we are going to teach it, pick the patient. Now, let me quickly say this. Whether you are in a sophisticated setting or you are not in a sophisticated setting, and we'll explain how that means, where you have all the gadgets, or you are in a primary center area, GH, where you don't have the luxury of all these things, you should be able to still do some postural drainage intervention for your patient. Now, all you need is a standard table, functional table, strong enough to carry the weight of your patient. Safety. Then you get as many pillows as possible handy. Then you also pick, what do you call it? A sputum mug, a disinfected sputum mug. It's just a container. You may have the ready-made one. If you don't have the ready-made one, you get I prefer a plastic being used, a plastic bowl. A plastic bowl. I wouldn't want a metal bowl to be used. The reason is that the metal one may be what do you call it, be getting rusted. The mucus that is put inside it may not be completely drained after you finish process, attracting more infection, causing reinfection. So that's why I would prefer, because if you don't have the ready-made sputum mug sold on the counter, on the table, you go for the plastic one that can easily be sanitized afterwards. And then you also have some wooden pieces that can be used to raise the foot of the bed, if need be, depending on the position that is adopted. This is even one of the reasons why postural drainage is a less expensive procedure, part of airway clearance technique. So now for people that, for apical segment affectation, this is the position. For anterior segment affectation, this is the way the patient will be put. Now, of course, lateral and medial segments, then apical segment, posterior segment. So these are the different positions that can be adopted. Don't forget, what we are trying to do is manipulate position to the gravitational positive effect that will help to drain the patient affected buccopulmonary segment, which is as a result of the prior examination that has been done through auscultation or through special investigation that have revealed the particular lung lobe that is affected, the segment that is affected. And for our colleagues in pediatrics, this is relevant for them for right middle lobe for the child. Of course, it's not all that comfortable. One thing about the postural drainage, even though I know I will highlight in subsequent slide, but let me quickly talk about it, then we'll flip it when we get to the slide. It's not a procedure that you do endlessly. Maybe has more like about 5 minutes because of it's a bit of uncomfortability. But you rate cost-benefit effect. That's why you're adopting it. If it is not an absolute contradiction, you go into it. So, but it's not an endless procedure. So for a child, you see this now. You see the hand of the, let me say this therapist now. Can you see the flexion at the MCP joint? Can you appreciate that? Are we together? Are we together?
Yes, sir.
Okay, can you observe the flexion at the metacarpophalangeal joint?
Yes.
Yes, sir.
Okay, you must do that. The flexion at the metacarpophalangeal joint is what makes the percussion easy. Of course, let me say at this point in time, now postural drainage can be with or without percussion or vibration. It can be with or without percussion or vibration. But from this infographic shown to you, it is implied that this is with what? It is with percussion, isn't it? Can we see it?
Yes, sir.
It's okay, thank you. So that is that. And then furthermore, this is also still with percussion, and this has to do with the right lower lobe. Of course, this is what I've already talked about. For us to be able to do percussion, you must flex your MCP joint. I'm flexing mine now, you put it in some reasonable flexion so that it can now, by the time you put in reasonable flexion, there's a bit of hollow at your finger palm, at the palm of your hand, hollow there, so that by the time you deliver it on the body, see the sand. That's the sand. But if it is flat, see the sand. It will be flattened sand. But if you're able to flex the metacarpophalangeal joint, bending it at the MCP joint, that's what I mean by the flexion, you'll be able to make that's the dampened voice. And the intention of that dampened voice is to introduce mechanical vibration through the chest wall to the lung pulmonary segment and dislodge any sputum that may be there. Of course, that is further enhanced, whose movement is further enhanced by the mucociliary action and completed by the other airway clearance technique, which finally culminated in expectoration. That is what it's all about. So that's what this slide is saying that I've tried to explain. Of course, there are contraindications to postural drainage, intracranial pressure, ICP greater than 20 milliliter mercury, unstable head and neck injury, active hemorrhage, active hemolysis, acute TB, and co-recent injection of food. Of course, that will be clear to us. The pulmonary edema associated with congestive heart failure, large pulmonary effusion, pulmonary embolism. Now, when you see PE in referral, it is pulmonary, it's pulmonary embolism. I want you to take note of it. It's not physical education, it's pulmonary embolism. In that instance, please probe further in the further medical history of the patient before you're able to adopt or not adopt. Now, I told you that sputum mobilization is a serious issue that has to be attended to in the issue of management of bronchiectasis. One of the gadgets that can be used is high-frequency chest wall oscillation, HFCWO device. We know TDP suit. We know the inner component of the 3-piece suit. The inner component of the 3-piece suit is like this vest jacket. I hope you are appreciating what I'm talking about. Or when you have a monkey jacket, or for some of us that are football inclined, we know the type of short sleeve sweater that Godiela used to use and Jose Mourinho. I hope we know that kind of short sleeve sweater. Do we know it? Are we together? That is, I'm using that to explain to us this first part of this highway ear frequency chest wall oscillation. That is what is now going to be worn, just like you are wearing that sweater. Just like you are wearing the inner piece of your 3-piece suit. Of course, that has a tube connected to it. It's a flammable tube. In the similitude of external pneumatic compression system, the one that deliver intermittent pressure, that is connected to this part of this machine, this one here, that generates that pneumatic compression intermittently. What it does now, depending on the setting you put it, as I am going to show to you now, is now connected to this vest. Once it's plugged to the wall, to the alternate current, it introduces that pressure through this vest to your body. And listen to me, what will be here. Intermittently. So that is now delivered to the chest wall. Those oscillating pressure is delivered to the chest wall, which is translated onto the lung field and the buccopulmonary segment for the sputum mobilization, and is now removed. That is the work of the high-frequency chest wall oscillation, HFCWO. Now, this generator here, this machine, it produces pressure of 50 centimeter water at a frequency of 525 hertz. It is delivered via the pneumatic vest. This is the pneumatic vest I told you, which surround the thorax. And the air pulses oscillate the chest repeatedly, causing transient flow increases, loosening the mucus, and producing the cough that expectorates. Does anyone have question on this? Does anyone have question on this?
No, sir, but I have a question on the positional drainage.
Okay. Where in this instance, somebody can be in sitting position. You will see what machine I will show to you very soon. Somebody can be in position because you see what do you call PD, postural draining was doing for you through gravity. Is this machine now that is now doing it for the mobilization? In PD, it is gravity that is pulling, that is applying the pressure. But here now we have a mechanical means of getting it done. I hope you appreciate what I'm saying.
Yes, sir.
So the person can be sitting. You see another machine now. I'm going to show to you. But one thing I want you to get is the mechanism behind this. This is a vest. It is worn. You see with Velcro. You wear it as if you are wearing a jacket. Part up here is Velcro down. Velcro down here, where my pusher is. Velcro down this part of the chest. Velcro down this part of the chest. Velcro down across the chest. So it's already stapled on the chest. It cannot be, the pressure cannot tear it open. Now, you now set your machine to 50 cm water at frequency of 522 hertz. Now, this pressure now is determined through this inflammable tube that is connected to the vest. And all this now cause transient flow increases in the airway, loosening mucus, and cutting out through the mouth. So we move on, please. For our colleagues in pediatrics, you see the same thing now. Okay, now, the one I showed to you earlier on was not one. It's for demonstration purpose. This is now is going to be one, whether adults or children. Can we see this picture? Slide one. Which slide are we? Which slide are we?
7.
Class, which slide are we?
Slide 117.
Okay, thank you very much. Can we see the first one now? Can we see it?
Yes, sir.
Okay, now, I hope by now we have been able to appreciate the wearing of it that I showed in slide 116, how the vest can be worn.
Yes.
It's okay, fine. So even though we are using this infographic for a child now, but that is the same way an adult will wear it. The only difference is that the Velcro size of the adult will be different from that of the children. So our colleague in pediatrics can take a clue from this. Now, for the person that asks question again, we will answer you. The recommended for use while in upright or sitting position. You understand me? And with concurrent use of aerosol bronchodilator therapy, especially when you suspect bronchoconstriction. And how do you know that? When there is wheezing. Then once the process adopted, you start from low pressure and frequency. You don't start from high pressure immediately. You see the tolerance. Hello? Are we together?
Yes, sir.
Okay. Now, I want you to appreciate about 2-3 things now. The position again, which answer what the one of the course attendant was asking, is sitting or upright position. With the use of bronchodilator, most especially when you suspect bronchoconstriction, which is identifiable through wheezing. Now, how do you start? You start with low pressure and frequency, and you begin to increase it to the recommended pressure.
Sir, we can't hear you. You've been off for more than almost a minute now.
Sorry, network cut me off. I'm back now. Can you see my slide?
Yes, sir.
Sir.
It's okay, fine. So have we been able to get this? Can I move on?
No, sir, you have to go back a little bit, please.
It's okay. Let me re-explain. But slide 116, you understood how I started introducing the concept from slide 116. You understood this concept that I started introducing from here?
Yes, sir. Yes, sir.
It's okay. Now, the same concept is translated to slide 117. But using the infographic of a child, and more now, our colleagues in pediatrics setting will be able to adapt this in case they have this in their center, which of course I recommend for centers to buy. Is that okay? Can we see it now? Now, I was trying to what do you call it? I was trying to explain to us the positioning is upright or sitting position with the use of aerosol bronchodilator therapy. In which instance, if it is suspected that there is bronchoconstriction, evidence in wheezing as a result of auscultation, or in high-profile cases whereby even without auscultation, you know there is wheezing. Now, but the rule is that start from low pressure and frequency and begin to increase it to the desired or the recommended frequency as the patient tolerates. Now, it actually helps a lot. The high point of its use, apart from the sputum expectoration, is that it causes airway flow increase in low lung volumes. I hope it's understood now. Is it understood? Are we together? Hello?
Yes, sir.
It's okay. Can I move on?
Yes, sir.
Can I move on? Or if you don't understand it, I will re-explain again. Let me re-explain. Can you see this velcro vest? Okay, it's okay. So let me go on there. Fine. Now, this is the sitting position I was discussing with you. This is an adult. You can use to try. We still call this one high frequency chest compression. You see now the lady is wearing it like a monkey jacket or a small sweater, sleeveless. And look at the two pipes that are connected from the machine. You just set it. And so in sophisticated centers where you have this, you just make the patient to wear it well fit you must make sure that it's well fitted on the chest because you are generated pressure. If it's not well fitted, you see this thing thrown open out and the efficacy of intervention will not be there. So you wear it. You wear it for the patient, ensure it's well fitted, but not unnecessarily tight, causing unnecessary discomfort for the patient. Then you begin to do the setting for it. So that is what it's all about. Of course, this is another mode of it. Of course, you can appreciate the Velcro vest easily now for it, for the way it is worn, and it helps a lot. So I move on. Now, in instances whereby you don't have a sophisticated system, and we still need to help our patient, what do? There's this method we can use, the positive expiratory pressure technique. We can help to mobilize sputum too. Don't forget the primary problem, the primary challenge in a bronchiectasis is the sputum that has been generated, that if not removed, it can cause infection and reinfection. Now see what is done. You get like a bowl of swan water. You get a pipe similar to this. Of course, make sure its septic condition is well taken care of. It is not infected, it is clean, it is sterilized very well. Both the bottle and this, so that we don't do reinfection in the case that we already have background infection. So you get that pipe that has fulfilled all these conditions. You get water inside that bowl of swan water. I hope you are appreciating it. Then the patient to begin to blow into that water as if you are making bubble. Through that, you can mobilize mucus. And before you know it, the man expectorates it out. I hope you get this concept very well.
Sir, yes, sir.
It's okay. I'm trying to adapt us to different practicing scenario. Because, you know, there are different practicing scenario. There may be a scenario that is well sophisticated. That is those machines I've given unto you. And also a scenario that is not also well sophisticated, and we can't leave the patient without attending to. That's why I'm bringing this different concept for us to be able to adapt to, for us to be able to master, so that we can replicate it on our field. I'm happy that we're able to understand this. So all these pictures show the same thing. Can you see the mouth? Of course, this goes to the mouth. And then the man breathes. Now, I would suggest that there should not be unnecessary flexion of the neck in getting this done. Because if you flex the neck too much, you are already reducing the potency of the airway. There will be a lot of struggle to get this done. Just a little flexion at the neck
in blowing into this bottle. I hope you
So,
appreciate
what is
that.
the level of that water in the bottle?
There's water in the bottle.
What level?
It's
What
like almost
level?
like one, you can make it either 1/3 or quarter.
Okay.
Do you understand me?
Okay,
Either
sir.
quarter of the whole volume of the bottle or 1/3.
Okay, sir.
But please note this point I said. The flexion at the neck, on the head on the neck, must not be too much. If it is too much, you are already causing another struggle for the air to pass through. I hope you appreciate that.
Yes, sir. So what's the tube called?
You said what?
The tube. What's the name of the tube?
Just here is pipe, ear pipe. It is similar to the tube of spirometer. For some of us that have seen spirometer before, if you can get the tube of that spirometer, it can be used for this. You understand me?
Sir.
Okay, but it must
Yes,
be tied
sir.
that it's elastic. If you look at it, it has serrated edges. It's not just ordinary tube. Can you see the serrated edges?
Yes, sir.
But please don't forget, the bottle must be sterilized, the pipe must be sterilized, and even when you finish, you sterilize both and keep it for another use, for another time. So thank you. I appreciate the fact that you're able to get this with all this pictorial that has been said. Now, bronchiectasis pulmonary rehabilitation settings. I want us to now move into settings now, even though I started talking about that. This can be conducted in a mix of settings. This is relevant to the context of our workshop because, like we see when I was throwing up epidemiology, I took us through diverse races, I took us through diverse settings, and I showed to us how this can introduce a lot of variance. So also in the management, the bronchiectasis pulmonary management, rehabilitation, the settings differ. It could be hospital community outpatient program, it could be home-based, it could be tele-rehabilitation. Now, exercise structure focus on moderate to high intensity endurance resistance exercises and duration is between 6 to 8 weeks that can be administered in the first instance for that patient for the duration, but it has to be moderate to high intensity gradually. And the high point of this, which I will show in subsequent slide, is that you see any chest condition, though not exclusive to bronchiectasis, even though we are discussing bronchiectasis today, is that one of the things that is affected is reduced exercise tolerance. And that has to be taken care of if the woman will still be relevant to his or her socioeconomic life. And that's the introduction of this. But it has to be, you can't start with high intensity. You have to start with from moderate intensity, and you graduate to high intensity depending on how the patient is able to tolerate it. And the co-interventions are this, apart from those airway clearance technique, the moderate to high intensity exercise we are talking about. The co-interventions are this: education. Of course, by now, you know that education, you already understand that importance of that. Self-management, of course, because the patient will not always be with you. And self-management protocols, you begin to get that positive respiratory flow intervention that I showed to all the small bottle. The airway clearance technique I've talked about, the respiratory muscle training, RMT, later on, just to make sure that the weakened respiratory muscles can be attended to. Now, rehabilitation with or without co-intervention has been shown to improve functional tolerance as reflected in incremental shorter walk distance over time in a clinically stable patient. So whether it has co-intervention or it doesn't have co-intervention, it has improved exercise tolerance in patients. That shows the efficacy of our intervention as physiotherapists, as cardiopulmonary specialists. That means we'll be able to successfully help a patient out of his or her condition. Now, though this was originally designed for and applied to those with COPD, I want us to take note of this. It has now actually been seen that it has similar degree of benefit in bronchiectasis. It was formerly demonstrated in patients with chronic obstructive pulmonary disease. But now it has been shown that it has similar degree of benefit in people too that have bronchiectasis. Now, pulmonary rehabilitation, in addition to regular chest physiotherapy, has also been shown to improve the exercise tolerance and health-related quality of life in non-cystic fibrotic bronchiectasis, and the benefit can be sustained 12 weeks post end of pulmonary rehabilitation. That is gladdening, isn't it? That means even after you have left the patient can be like symptom-free for 12 weeks. That's also a good news. Now, we look at supervised exercise training session by experienced cardiopulmonary physiotherapists. There is upper and lower limb exercise training, aerobic walking, and cycling. And these are demonstratable research work. Now, I want to particularly look at this one, which is a study of that was done sometimes in 2019, still very recent. It has to do with pulmonary rehabilitation and bronchiectasis. It's a propensity match study. And the study actually was concluded that this it concluded that there is improvement, an improvement that is gotten, which of course shown improvement in exercise capacity, improvement in health-related quality of life. It has been shown that this improvement, as well as its adherence and completion rates, are of similar magnitude to those that have presented with COPD, just like the other one that I showed to you. So whatever the improvement you saw here is also the kind of improvement that is being observed in patients with chronic obstructive disease. And those improvements are noticeable in the exercise capacity. The patient will be able to do more. And if there is improvement in the exercise capacity, the patient is able to cope with his life at home. The patient is able to cope with her life in the place of work. Now, what does education session entail? We want to quickly look at it. Education sessions actually are effected by multidisciplinary team with topics that are chosen to develop the patient understanding and the holistic management of the condition. We have to sit down our patients to understand the condition and to understand the intent of purpose of our management. Very, very important. One of the things we need to do is the importance of exercise and physical activity. We need to let them know. The medication of use, we need to tell them that they are prescribed drug to them by their physician. They need to adhere to it according to prescription. And we may need to ask somebody to also, we can be asking the caregiver that follows them whether they are doing it. Because we know we have said that a failure of ineffective intervention will be a precursor to surgical intervention. So we need to look at those, the diet, the coping mechanism, the relaxation technique, all those things we are going to probe into. And those are reflected actually in the European Respiratory Society guidelines for the management of adults that are presented with presented with bronchiectasis, the 2017 edition. This shows to us that all interventions should be tailored to the patient's symptom, physical capability, and disease characteristics. I want us to add this at our fingertips, that all this intervention in bronchiectasis management, it must be tailored to the patient's symptoms. It must be tailored to his capability. It's not just imported and dumped on the patient. It is tailored towards his capability and according to the characteristics of the disease that is presented with. I've taken time to explain to you. Of course, you would remember now that this is like a grade 5, a cluster from the ICT, the HRCT, high resolution computer tomography that I showed to us before. You will see now that this is what do you call it? We have cluster here. Here we have cap lines, then presentations. So I need not to bother too much about that now. The next phase of this our training today is to look at how physiotherapy can harness the vicious cycle of bronchiectasis for effective treatment. But before I go into that, because we'll be back within the next 2 minutes at 1:26. Thank you. Please stretch your leg. Thank you. We are back in class. Are we together? Are we together?
Yes, sir.
Thank you. Now, I want you to the thing I do emphasize on, and that actually determines the way this workshop is packaged, the slides are packaged, is to understand the mechanism of what is going on. Once you understand the mechanism of what is going on, the way you are going to come in as the expert, as the professional, will be so unique and will be so strategic in the management of the patient. That's why slide 34 again is almost like a chronicle of some of the things I've been explaining to us. But I need to re-emphasize this to us. This is what is happening in bronchiectasis. I want you to look at it very well. Now there is impaired mucociliary clearance and accumulation of mucus. Because of that, it's a cyclical issue. Now, because of that, there is bronchial obstruction, lung damage, and structural lung disease. Because of bronchoconstriction, lung damage, and structural lung disease, there is microbial colonization and infection and reinfection. And because of this, there's neutrophil inflammation. Of course, that's why you have increased WBC. And because of this, there will be further impaired mucociliary clearance and further lung destruction, further microbial infection. That means anything that has to be done now must be something that can reverse this cycle. Did we get that? Did we get that? Class, did we get that? Are we together?
Yes, sir. Yes,
Do you
sir.
want me to repeat it? If you did not get it, please tell me, I will repeat it. Did you get it?
Yes, sir.
Can I move on?
Yes, sir. Yes, sir.
Okay, thank you. So let's go to 135 now. Now, this is summary of intervention for the management of bronchiectasis with associated level of evidence. Now, when you see this benefit from intervention, several high-quality randomized trials show that airway clearance technique is effective. Pulmonary rehabilitation, when clinically stable, is also effective. Then, for uncontrolled trials or expert opinion, it showed non-invasive ventilation is okay, rehabilitation pre and post-operative transplantation is okay, education and self-management is okay. Then for single high-quality randomized trial or several low-quality randomized trial, it shows that domiciliary humidified oxygen therapy will be effective, respiratory muscle training will be effective, the mucoactive agents will be effective. Then the one that shows no effect from the intervention is pulmonary intervention during an acute exacerbation. Of course, that shows the necessity of doing some preliminary treatment that will help to control local infection before moving in. These are further details. You will notice that in the examination of the patient, I told you that very unusually and very uniquely to bronchiectasis, you need to examine whether there is you need to ask in the history taken whether there is history of urinary incontinence, which will be stress incontinence. And if you are certain, this is the basis, scientific basis for it now. The reason why we go into that very unusual in a chest condition. Now, there is documented evidences of high prevalence of stress urinary incontinence in adults with bronchiectasis. Now, the self-reporting of stress incontinence in bronchiectasis is actually poor. Patients don't discuss it. They don't actually admit it, and it can be left untreated. And you know what it means if it is left untreated? If it is not screened, it will be left untreated and there will be deterioration. But if it can be picked, it will be screened, then there will be physiotherapy intervention to it. Of course, the reason why there could be stress incontinence is because probably due to the coughing and the forced expiratory maneuver, which with reduced mobility in some instances. The cough, you know, is with struggle in some cases, depending on the severity. And then there's a lot of force that the man or the woman begin to use to cry out. And I want you to try forceful cough. and tell me the effect on the pelvic floor muscle. Do that within a few minutes. Do forceful cough. I want you to do forceful cough. What happens to your pelvic muscles? You can unmute and talk. What happened to your pelvic muscles? Hello? Are we together?
They contract.
It will contract, isn't it? What of
Yes.
if your bladder is full? What will now happen?
It relaxes.
And the person can wet, isn't it?
Yes.
That's exactly what happened in a bronchiectasis. I'm using that analogy for you to appreciate what we are saying, that it's not theory. It's actually real. And that's why it has to be picked in history taking. It has to be picked if we are able to ascertain it in history taking, we'll go into the screening for it, and then we'll enlist it as part of our management. Pelvic floor muscle strengthening is part of the protocol. Oil suppression till you get to the nearest point of voiding the bladder retraining, and toilet rescheduling are protocols that we can incorporate into management for that one. Now, PT interventions may also be useful for postural or musculoskeletal dysfunction and pain. We have been able to establish that there will be postural and musculoskeletal dysfunction and pain. So physiotherapy will be necessary. Also, ergonomic assessment of the patient's work and home environment may be indicated to maximize function in these settings, to make it more comfortable for them, vis-a-vis the presentation of the postural and musculoskeletal dysfunction that they are going to have. Then there will be preventive health practices. You prevent cold and flu. If you know the person is susceptible to cold and flu, you have to give adequate education to help the person. And if it's also going to be that the person will relocate from his place during that particular time of the year, the person may get leave and leave that location. If the person cannot completely leave the location for now, they get leave during that time. And this part of the education that will give them: smoking cessation, sleep. Of course, all of us, we have agreed. In the pictorial of the pathologic bronchiectatic lung I showed to you, we have agreed that it's possible that the sleep will be affected. Now, you may have to also educate on good sleep practices, relaxation, stress management, the nutrition, the hydration, and the weight control of the individual. I will go into the outcome measures now that we can use, because we are in the evidence-based era. So within 1 minute, I will go into that. Take deep breath. I want you to take deep breath before we move on. Deep breath. It's okay, fine. You are welcome back. We're going to outcome measures. These are the outcome measures that can be used in the management of bronchiectasis. We have the BMI. You know, I told you there's possibility of weight challenges in them. And so you continue to check the weight and incorporate the BMI to see how it's fluctuating and what it is. Then you also look at the spirometry, which, of course, you know, earlier in this workshop, as part of foundational factor, I laid down to us some tests that should be done for the lung. One of them is spirometry, which has to do with the flow of air in and out of the lung, objectively done. Of course, this is a big gadget that not many centers actually have. It's a center that has a big boast. It's a highly developed center. So spirometry will attend to that and ascertain that it is going to show the level of depreciation or function or otherwise of the lung. Then there is 24-hour sputum volume. The patient collects the expectorated sputum. Don't forget there's something I call sputum mug. What sputum mug is all about is like a container where sputum is put inside. I told you it may be, the infection control must be there, but it must be well protected and then put there. So the weight in the morning is taken when the thing is without sputum, and as they collect the sputum over time, after 24 hours, they take the weight again, and the differential in the weight is going to be the weight of the sputum. But take note. I want you to take note. I'm repeating it, take note. Is the weight differential you are going to get is not in kilogram. I hope you are getting me. Are we there? Are we there?
Yes, sir.
Okay. The weight differential is going to be in gram. In fact, when you examine literature, when they talk about the efficacy of intervention, when you go to efficacy of intervention of the pressure drainage and co, in most work in central, in cystic fibrosis and the like, you will see that the weight differential is in gram, it's not in kilogram. So if I give you an objective question, I put a weight differential to be kilogram, you should definitely know that if it's yes or no answer, the answer should be what? It should be no. Because it's not necessarily, can't necessarily be kilogram, it's in gram. But 1 gram is equal to 1 mil of sputum. Did we get that?
Yes, sir. Yes, sir. Yes, sir.
So I go on now. So I want you to take note of the next 4 slides, 5 slides. It's going to interest you on some outcome measure. If I think that you can, let me use the word deliberately, play with. When I mean play with, something very handy, very, very handy that you can do to do these measures. Now, I've talked about spirometry, I've talked about sputum measure. Then I want to go into scoring system now. There's something we call BRICS and BSI. BRICS is bronchiectasis radiologically indexed CT score. That has to do with those radiological diagnoses I told you about. I will show to you how it's done very soon. Then BCI has to do with bronchiectasis severity index. These are simple processes that can be adopted. So my arrow is saying, look forward to see it. Let's go into BRICS. Now, BRICS is a severity assessment score for bronchiectasis. It was actually developed for cohort of patients with idiopathic and post-infectious bronchiectasis. And it was developed by combining the parameters of bronchial dilatation, which I've talked about earlier on, and number of bronchopulmonary segment that is affected in the instance. Now, how is the scoring done? I want you to take note of it. Simple scoring is 2 domains. What are the 2 domains? Bronchial dilatation and number of bronchopulmonary segments involved. Hello, are we together?
Yes, sir.
It's a very simple procedure. How many domains does he have?
2.
2 domains. What is the first domain?
Bronchial dilatation.
The second domain?
Number of segments affected by emphysema.
Now, the first one, the maximum score is 3. The second one, the maximum score is 2. That's why any score is over 5. Now, let me go to bronchial dilatation. When there is no bronchial dilatation, it's 0. When the lumen is greater than 1, it is mild. Yes, it is mild. And when the adjacent, when the lumen is just greater than the diameter of the adjacent vessel, it is 1. Don't forget the initial adjustment I gave to you that in some places there's high altitude can be between 1 to 1.5. I hope you remember. But
yes,
once it's about 1.5, they say it has gone up. So when it is moderate, when the lumen is 2 to 3 times diameter of the adjacent vessel, it is 2. Of course, these are not figures you will manufacture. It's in the test. You just pick it from the figure of the test, and you now knock it in and know where it gets. When it is severe, which is greater than 3 times the diameter of the adjacent vessel, it is 3. Now, when the number of bronchopulmonary segment, if there is none, is 0. If there is 1 to 5, is 1. If there is
You're breaking up, sir.
Now, look at the scoring system. Okay. Any question? Any question?
It's okay.
Your network was fluctuating.
I should go over it?
No, sir, continue.
Yes, sir. Yes, sir. Yes, sir. I can go over it, sir.
Okay. Now, there are 2 domains. The first domain is bronchial dilatation. The second domain is the number of bronchopulmonary segments with emphysema. Now, the first domain, bronchial dilatation, the score is between 0, 1, 2, 3, which has to do with the lumen compared to the adjacent vessel. I told you these are not figures you manufacture. These are figures that come from the test that have been done. You just plug it in and now know where it stays through. Now, when the lumen is just greater than the diameter of adjacent vessel, it will be 1. If it's 2 times 3 times greater, it will be 2. If it's greater than 3 times, it will be 3. Then the next domain is the number of the BPS affected. If it is none, it is 0. If it's 1 to 5 segment, it is 1. If it's greater than 5, it is what? 2. That's what gives you, if there is no or none of this, it will be 0. The score is between 0 and 5. So this is the scoring system. With 1 indicates mild disease. When the score is 1/5, it is mild disease. When the score is 2 to 3/5, it is moderate disease. When the score is 4 to 5, it is severe disease. Do we get that?
Yes, sir.
Sir, I have a question. So if we are calculating this, is this going to be based on for example, if you are calculating the bronchial dilatation, would that be based on the largest?
Do we get that?
Hello?
Do we get that?
If there is network issue. I think he's having network challenge from his own side.
Sorry, network me out. I'm back. Sorry, please. Now, did we get this slide very well? The explanation on this?
No, sir.
I should go over it again.
The question, sir.
Yes, sir. Thank you, sir. Yes, sir.
Okay, so we can move on.
No, sir. I had a question, sir.
Okay, go ask your question.
The question was that when you are calculating the bronchial dilatation, is that going to be based on the worst affected segment?
Yes, with the adjacent one. Like I told you, you are not manufacturing a figure. The test will show you. You understand me? The result of the test will show you. Hello?
Yes, sir, understood.
Does it mean that from the result of the test, from the report,
Yes.
this figure here will be indicated, and from there we'll be able to know which one is indicating moderate disease, mild disease,
No, you pick figure from the test. Do you understand me? You now come back here. That figure, what did that result say? Did it say that it's just slightly above the adjacent? If it says it's just slightly above the adjacent, that would be 1. I hope you are getting me. If the result says that this is 2 to 3 times more than the adjacent, that would be 2. If the result is telling you that the lumen is 3 times the adjacent, that would be 3.
All right.
Okay. Thank you. So let's go to the second one. The second one is not as simple as this, but what is this one is called PSI. Bronchiectasis Severity Index.
Has a question. Somebody wanted to ask a question.
Severity Index. Network, let me wait a bit. Okay, go ahead, please. Please speak. Ask your question.
The score.
Ask your question, please.
Hello, sir.
Hello, please ask your question.
The range of this score 0 to 5, which is a mild disease, is it only for bronchial dilatation alone?
Yes, you know I told you it's 2 domains. For this particular one, I'm going to show you 2 quick ones. But this particular one, this one I'm showing to you now, is just 2 domains of assessment. That is bronchial dilatation, then number of bronchopulmonary segments. It's a very simple tool.
Okay, sir.
Yes.
How we bind
so let's move to the second one. Okay, you still want to ask? Okay, go ahead and ask your question.
How do we bind the two together to arrive at this 0 to 5, 2 to 3?
bronchodilatation.
Sir, how do you
Hello?
combine these two together? Hello, sir.
And that's what I'm saying. The score now, let's assume under bronchodilatation, the score is 2. Now,
Yes.
if under number of buccopulmonary segment, the score is 1, that will be 3/5.
Yes. Okay, sir.
You understand?
Okay, sir. I'm clear now.
Then that 3/5
I'm very
will
clear
not
now.
mean moderate disease.
Okay, sir. I'm clear.
You understand? Now let's pick another imaginary scenario. If the score under bronchodilatation is 1, and the score under the number of buccopulmonary segment affected, the score there is 1. 1 plus 1 is what? 2. What will 2 mean?
2/5. 2/5.
Okay, what does it mean in interpretation?
That's moderate.
Moderate, that's good. Let me give another scenario. If we have bronchodilatation is 0, and then we have number of bronchopulmonary segments involved is 1, that it will be 1/5. What does it mean?
Mild.
Okay. Thank you. Now I'm going to ask you a question further on that. With your knowledge so far in our discussion today, which stage will you think is bronchiectasis? Is it the occult, the insult stage, or the vicious circle stage?
The vicious circle.
You may not have gotten there. It may be in the early style because it's 1. That's the point I want to bring up. You understand me? You don't have bronchodilatation per se. You're just having a segment that is affected.
Okay, because
You
it's
understand
permanent.
what I'm bringing up?
Yes, sir. Dilatation has happened.
Let me move on. Any question again?
Go on, sir.
Okay, thank you. Let's go to bronchiectasis severity index, PSI.
Your network.
This one is a bit advanced to the other one, but it's also simple. Okay, let me wait a bit for 1 minute. Hear me now?
We are hearing you, sir.
It's okay. Now let's go. The score here, like I told you, is a bit elaborate to the other one. That one is just 5, 2 domains. But see this particular one now. It has a 1, 2. It has 2, 3, 4, 5, 6, 7, 8, 9. 9 domains. But the maximum score is 25. And it's also something easy to compute. You look at the years. The year fake people score. If somebody is less than 50, it has 0 point. 50 to 59, 2 points. 70 to 79, 4 points. The maximum points under the age is 6 points for people greater than 80. Then this is the essentiality of taking weight as part of our examination. If the BMI is less than 18.5, the person scores 2 points. If it's more than 18.5, the person scores 0 points. Then you look at the FEV1 percentage predicted. Then, of course, this has to be through the spirometry process done. Now, greater than 80, 0 point, 50 to 81 point. Then look at the number of exacerbation the person have in the last 1 year. In the last year, if the person has 0 to 2 is 0 points. If it's greater than 3, 2 points. Then the number of admission through in the past 2 years is rated either 0 or 5 points. If the number of admission is greater than 1, the person score maximum of 5 points. Then the Medical Research Council dyspnea score scoring system. If the person has on 1 to 3, there the person scores 0 points. If the person is on 4, the person has 2 points. Then colonization with this particular, don't forget I told us that there is sputum examination. Now one of our relevance could be that get us sputum for laboratory analysis. Now in that instance, the sputum, that the organism that is isolated, if it is decolonization by these pseudomonas, the person, if the person will score 3 points. But if there is no pseudomonas, the person will score 0 points. Then if there is colonization with other organisms, the person will get 1 point. If it is no other organism that is there, the person will score 0 point. And very lastly, the number of lobe that is involved radiologically, if it is less than 3, the person scores 0 point. It depends, it's greater than 3, or when it's already confirmed cystic fibrosis, the Perry score 1 point. And you now add the score for all the domains, for all these about 9 domains. When the score is 0 to 4 points, between 0 to 4 points, it is mild bronchiectasis. If the score is between 5 to 8 points, it is moderate bronchiectasis. If the score is greater than 8 points, it is severe bronchiectasis. Let's have a little pause and look at it if you have questions. Any question? Can you apply this now? Can you apply this on your field now? Hello, are we together?
Still thinking on it, sir.
Okay, can we apply this now? Did we get it?
Yes, sir.
It's okay, thank you so much. So this are thing I expect that you go back, you continue, you study it over and over again. In fact, I don't think it will take you up to 5 minutes to be able to fully understand this short what do you call it, outcome measure that I've given unto you. Of course, there's something called NYHA scale. That has to do with New York Heart Association, which was developed for patients with cardiac disease. Don't forget, I told us that one of the possible complications is this. And this has to do with symptoms, either at rest or upon exertion. It's class 1, 2, 3, 4. So when there is complication of this, we can go ahead and administer it. When there is no symptom with ordinary activity, breathlessness only occur with severe exertion, that's class 1. When there is symptom with ordinary activity, that's class 2. When there is symptom with mild exertion, class 3. And when there are symptoms at rest, that's class 4. That's very simple. That has to do with symptoms and where the symptom is taking place. Is it at exertion or is it at rest? Is it much or is it not much? Of course, all this one I outline here now are things that some of them should not be new to you before again, because it's adapted, it is slotted into some of those 2 other scales I've discussed. The dyspnea score, the BOSS score, the health-related quality of life. We have agreed, we have seen in our workshop today that the health-related quality of life of patients is affected, so it needs to be assessed, both the generic and disease-specific one. Of course, the 6-minute walk test is very, very important that we do it to ascertain the exercise tolerance of the patient. Of course, the CRP fatigue domain, the 2-minute walk test can also be adopted. The endurance walk test, the Lisa cough questionnaire can be administered. The hospital anxiety and depression scale can be administered, because we have agreed that this affects the quality of our life of the patient. So that's the necessity of administering all these outcome measures that I talked about. Then there's maximal incremental treadmill test. I told you that for cardiopulmonary conditions, treadmill and bicycle ergometer is very essential for centers to have, because they will be used for stress test. So for maximal incremental treadmill test, there is what we call progressive exercise testing, which is done on treadmill using what they call Barclay protocol. And what it's all about is that after initial recording of resting measurement, 2 minutes, the grade is increased from initial 0 grade by a gradient of 1% each minute. And it continues like that. And then the patient response is monitored on it. That is what it's all about. At the termination of the test, the end of the exercise dyspnea is rated through the exercise dyspnea scale, the box scale, it can be used. Then the peak oxygen uptake is also recorded, which is in mil per meter per kilogram. Of course, this has to be a sophisticated laboratory condition where these are obtainable, where you can, except it's going to be computed. It can be computed in some instances through some formula, but in some instances, be obtained from patient. Network is unstable again. Let me hold on. You're welcome back. So the same thing, apart from strength test, there's submaximal exercise test. It has to do with the measured at 85% of peak maximal oxygen consumption achieved on the baseline. The patient's the resistance is increased, and the patient and then the patient is stopped. The distance that is covered is now recorded for that patient. Then, of course, the heart rate is noted down. The oxygen saturation is also noted down through the use of our pulse oximeter. There's also the incremental shuttle walk test, which has to do with walking at an increased speed up and down at a 10-meter course, which is separated by 2 poles, according to a method that was described by us. This is terminated when the patient is no longer able to maintain the required speed. Of course, the speed is redetermined. It is at a particular reading, measured, specifically monitored. Now, if the rhythm of walking cannot be maintained again, it shows the patient as what do you call it? Is tired, and then the patient may become breathless in the process. So it is stopped, and the time and the distance walk is now monitored. So let me stop here now and ask us for questions before we begin to go into further details and we go into case presentation. Question time. Can we go?
It looks like the
Are we go on?
Just
Are we go on?
Sir. Hello? Sir. Hello?
Thank you. Let's look at the prospect of physiotherapy intervention in the management of bronchiectasis. What is the prognosis? Currently, bronchiectasis has no cure. Most affected people can actually enjoy good quality of life, and they can manage the condition with stress-wise treatment, clearance techniques, the method physiotherapy teach them, so that there will be prevention of infection and reinfection. But we need to say that early diagnosis and treatment is very important, and also treatment of underlying condition, they are very important to optimize chances of recovery. Then for the use of postural drainage and percussion, both of them are actually effective. They have been proven to be effective. So we have reason to actually be able to talk about the efficacy of our intervention. And these two help in the mobilization of the pulmonary secretion. And this also helps in bronchus clearance. And this will invariably reduce dyspnea for the patient and improve their quality of life. It's also been shown that combined effects of antibiotics and chest therapy
Your network,
of course, you know what that means because the isolated
your network.
Are you hearing me?
It's breaking. Your network is breaking.
It's okay. Let me wait a minute. It's okay. I'm talking about combined effects of antibiotics and chest physiotherapy. It's been shown to have significant effect on airway clearance. And it also reduces your occurrence. And I was trying to explain that out. If it has significant effect on airway clearance, you expect that dyspnea will be reduced. You expect that there will be better breath sounds. You expect that there will be reduction in spiritual quantity. You expect that the SpO2 will improve. And if those improve, you actually expect that the patient will have a better quality of life. Also, combination of antibiotic and chest physiotherapy is been shown to be more effective than antibiotics alone or chest physiotherapy alone. That means combinative therapy is the mode of attention that will be more productive. It is possible to have antibiotics alone. It is possible to have chest physiotherapy alone, but it's being seen through research studies that a combination of the antibiotic and the chest physiotherapy is actually more productive intervention. Now, we look at case presentation now. What I'm going to do under this case scenario, we have gone so far, about 154 slides in this presentation. So I've taken you extensively on bronchiectasis. What I'm going to do now is that we're going to do as if we're in face-to-face classroom. Face-to-face classroom for these discussion cases. So I term it theoretical with practical clinical illustrations. So we go on. This particular one is a RCT, randomized control trial, and it has to do with airway clearance in bronchiectasis, a RCT of active cycle of breathing which incorporate postural drainage and vibration versus test of incremental respiratory endurance. Two protocols they adopted. The first protocol will be ACBT, airway clearance technique, which incorporates postural drainage and vibration. Then the other protocol will be that of incremental respiratory endurance. Now, what this study came out with is that ACBT that incorporates postural drainage and vibration is more effective method of airway clearance technique than that of test of incremental respiratory endurance. I hope that is clear. So it therefore suggests that active cycle of breathing, which incorporate postural drainage and vibration, is more important. And then you can actually explain that out in the sense that there's a lot of mucus clearance, massive mucus clearance, because of the intervention that is adopted. And that means this protocol is a protocol that can be replicated in some other cases. That's the first presentation I have for us. The second presentation I have for us is the one that we are going to discuss. Now, we move together. We have a case of 42-year-old man. He works as a gardener, but has been finding it difficult to maintain his business recently due to recent respiratory infections. He has had a long history of respiratory problems starting in early childhood. He thinks he was told that he had asthma, previously used an inhaler, but stopped due to it being effective. Let me stop there. What is your thoughts in view of what you have been taught today? Hello? Hello?
Yes, sir.
What is your thought in view of what you have been taught today on the history of this man? I want you to talk specific in terms of what we have been taught. Use scientific language, then explain out.
From
Now,
the
let me guide you.
presentation, he may be having some congenital history, according to the say from child.
Let's clap for him. Yes, because it started from childhood, isn't it? You got that right. But what is the other fact?
Yeah.
Hello?
Yeah, he stopped using inhaler due to, he said, he's inactive.
Yes, but I want you to take note of something. It went undetected. Can you pick that from the history?
Sir.
Recurrent.
Can you pick that from the history?
Yes, sir.
Yes, they say he had recurrent respiratory infections.
Yes, he had recurrent infection.
Maybe he has bronchitis because when he uses inhaler, it doesn't have effect on the condition.
Yes. And then the issue now is that they didn't detect it. Nobody diagnosed that it was bronchiectasis. I hope you pick that from the history.
Yes, sir. Yes, sir.
At the early stage, nobody diagnosed. They were just talking of infection alone.
Yeah, that's
Isn't
true.
it?
That's true.
Okay. Now, in terms of morphology or presentation, Which type of bronchiectasis did this patient now presented with? Finally.
Cystic and varicose bronchiectasis.
Cystic and varicose, thank you very much. Incidentally, affecting how many lobes?
All the lobes.
You expect that in those severity index I gave to you, the patient will score very high, isn't it?
Yes, sir.
Isn't it?
The
Yes,
person
sir.
should mute.
The match, okay, the on.
Please mute yourself. Mute yourself. So the patient will score very high in those severity index scale that I gave to you, either the 1/5 or the 1/25, isn't it?
Yes, sir. Because he has at least 8 lobes affected.
There's still one thing I want you to pick from here, so that you know that what we have taught is not theoretic. I'm deliberately bringing out this case presentation in a theoretical form, but with practical illustration, so that you know that the part we have taken in the course of this workshop is a demonstrable part in the life of patient. Now, can you see he has often struggled to gain weight?
Yes, sir.
Have we talked about today? Have we talked about that today? Okay. Now, can you also see this? It tends to cough most days and has 3 to 4 significant chest infection per year.
Yes, sir. Yes, sir.
Does it look like what we have talked about today?
Yes, sir.
Okay, thank you. Let's move to the next one. This is another one. Now, it's a case of a 45-year-old architect. He has had asthma since childhood. It has generally been well controlled throughout most of his adult life, with only 1 or 2 exacerbations and no hospital admission. In recent years, he has noticed a decline in exercise tolerance and an increase in cough, which has become productive for purulent sputum with occasional thick, solid components. He has had several significant respiratory exacerbations, which has not responded well to standard steroid and antibiotic treatment. One of these episodes was so severe it required emergency hospital admission due to respiratory distress. This improved when he managed to expectorate some very thick mucus. He was noted to have variable pulmonary infiltrates or chest radiograph during this episode. What is your thoughts?
He said it is well managed, but there was no mention of having chest physiotherapy. So it looks like he was very highly dependent on medication to manage his symptoms. And it looks like he had worsening of his respiratory issue, likely bronchiectasis over time. So my thoughts are perhaps the statement of it being well managed was just that it was well managed, but there was no surveillance of the progress of his chest situation over time.
Fine.
In addition to that, it's also congenital.
That's
asthma is
another thing.
Sir,
yes.
Asthma is one of the risk factors of bronchitis. The patient has asthma initially, which become exacerbated and it turned to bronchitis. That's what I know.
Yes. And then, thank you very much. What else do you notice about the pattern of the cough and the sputum?
I think the only thing I saw was exercise tolerance, which worsened over time, and then the quality of sputum.
Very thick one, sir.
Very thick one, thank you. And purulent, foul smelling, isn't it?
Yeah,
and
so
if
infection.
it is thick, I told you of medications for it, isn't it?
Yes, sir.
Yes, sir.
I call it what? Mucolytics.
Yes, sir.
I told you it helps to soften so that it can ease our work. Because if it's not softening, the airway can go into bronchoconstriction and there will be serious effort to bring out, and there will be wheezing. Or alternatively, you do inhalation or steaming to steam it, because when you steam, the moist water that goes into the nasal passage, it will help to soften the mucus. I hope you pick that. It's okay. So fine. Let's go on. Now, let's go to this now. A 66-year-old woman with established idiopathic bronchiectasis has had 3 to 4 exacerbations per year in the past 3 years, despite performing daily chest physiotherapy. This testing for non-tuberculous mycobacteria and this aspergillosis, I told us, and other complications were negative. But sputum shows persistent infection of her pseudomonas. She produces large volumes of sputum daily despite performing the active sample of breathing technique. What's your thought?
Pseudomonas aeruginosa has a very high implication on the severity score as opposed to other infections.
Okay. But you also note that this person will not get any score under other infectious organisms.
Yes, sir, just like 1 or 2.
Okay, fine. Thank you. Or acquired. Is it congenital or acquired?
This is acquired.
Or acquired?
It's acquired. It's acquired.
Acquired. Thank you very much. It's acquired. Now, what other observation do you have?
He has undergone physiotherapy. I've been referred for physiotherapy, sir. And he had 4 excavations per year.
Okay. So the excavation has been much per year. About 3 to 4.
3 to 4 excavations per year for the past 3 years.
Yes.
Yes,
so
sir.
that's significant. That means actually rated. Now, what do you expect of the clinical presentation of this patient? Because we didn't say, this is not highlighted now what I gave to you. What do you expect in this patient in terms of examination?
He has a sputum so persistent infection.
Okay. In terms of physical things that you are going to pick out in examination, what are the things?
The volume of sputum.
I expect lower levels of oxygenation and fatigue levels due to high production of sputum and blocking of the airway. I expect it to the person has active cycle of breathing and is not working. So I expect the person will also be fatigued because of it.
Thank you. Thank you. We're flowing. Thank you so much. Let's go to another case presentation. Let's look at this person now. 68-year-old client was referred to chest physio for us, the chest physio to manage chronic bronchiectasis. Now, this client has recently from abroad and has never researched to how a physio will be able to help her in any way, but was open to trying anything as she was quite frustrated with her symptoms. What are the presenting symptoms? She was presenting with minimal to no shortness of breath, mild of breathing, and could hold a full conversation without having to catch her breath. She was finding that in the morning she would struggle to clear her chest effectively and always felt as if there were crackles in her chest. This was particularly frustrating to her as it was limiting her ability to go for walks comfortably and go out for coffee and her friend, as she would be coughing to clear the crackles. Then we need to excuse herself to cough up the gunk that was sitting there. She was becoming increasingly frustrated and embarrassed by this. Discuss your observations. What are your observations? What are your observations?
It sounds like most of the accumulation happens when she's resting and it's worse in the mornings, and most likely worsened when she's staying still. It doesn't seem like the rate of production is very high. It's slow, so it slowly builds up for her. So I think the issue here would be what is the cause of the collection, especially since she has an history. So it's what assessment has she done? Is it infection that is driving it? Basically what is driving the infection? Sorry, the production. So I think I want to know what kind of assessment she has done to know the severity as far as mucociliary transport is concerned, the level of damage to lobes of the lung, how quick, because the BMI, basically the factors around the severity scale, they can help me add up what exactly is contributing to the severity, and then we can know what has not been addressed yet.
Thank you so much. Particular note, which of course you have said, let me stress it, is that this usually happens in the morning. That means over the night there's mucus built up. Probably her activity during the day has been of much help for her to prevent the built up. But during the night, when she couldn't clear much, there's built up of the mucus. We need to take note of that. The other thing we need to take note of, apart from what you have said, is our quality of life is being affected, isn't it?
Yes, sir.
Yes, it is. It is the embarrassment while going out. He couldn't go out with friends for coffee and other.
Exactly. So, and these are the things that are paramount to her. You know, when we treat patients beyond the symptoms alone. We also treat patients in the holistic part of his or her life, that how has this been able to affect him, this man or this woman? And this is significant for us to really attend to. But of significance is that this man, this particular client, has been somewhere else, he relocated. I hope we took note of it.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
And prior to this time, the patient has not received chest physio. I hope we took note of it. I hope we took note of it that physiotherapists have not intervened in our condition, in the condition of this patient.
Yes, sir. Yes, sir. We took note of it.
Okay.
That's
so thank you. We move on. So now let's now go back now. I think we're still talking about that patient now. I deliberately left out these slides. Now, our oxygen saturation level was between 94 to 96. Between 94 to 96. Upon auscultation of her chest, there was upper airway transmitted sound, crackles, in her upper nose bilaterally and right middle lobe. Her cough was wet, that means productive, and occasionally productive of yellow secretions. What does that mean?
Infection build up.
Infection.
What does that mean?
Infection,
There's still
sir.
underlying infection. Yes,
Yes.
infection. That need to be taken care of. So it has to be collaboratively managed, isn't it?
Yes, sir.
It's okay. So that this primary problem is also addressed. It's okay. So we and then of course there are secondary sounds, crackles, spread all over our lungs, here and there. So there's no doubt that physiotherapy is needed by this woman, isn't it? Do we come to that agreement?
Yes, sir. Yes, sir.
Yes, sir.
Infection.
We go on.
Yeah, want to reduce the load in the fluid, in the accumulated fluid.
Because of infection.
Exactly. And the accumulated fluid and the secondary sound.
Yes, sir.
Now, this is now what happened after some time. Let me quickly jump. Now, after some time, see what we are seeing now. Our pregnant felt empowered and in control of her condition, which she couldn't remember the last time she had felt that way. That's after series of intervention. She was able to effectively clear her chest and did not experience the ongoing crackles, especially in the morning. Plus, she was able to go and have a coffee with her friend and wasn't embarrassed about constantly coughing, and she had cleared her chest prior to leaving.
There are some.
She requires occasional chest physio. There are some what?
Yeah, the airways has been cleared through physiotherapy, chest physiotherapy.
So
and
it
the
looks
woman
like,
is happy with herself, isn't it?
yes,
Yes.
sir. It looks
She has
looks
been
like she
taught
got,
some coping mechanism.
yes, sir, an effective
Because
clearance.
why I said she has been taught some coping mechanism is that look at this statement. She required this statement says that she was able to go and have a coffee with her friend and wasn't embarrassed about constantly coughing, and she had cleared her chest prior to leaving. So she has been taught coping mechanism, isn't it?
Yes, sir.
Yes. So I hope we are flowing, we are getting how we can practically do this thing on the field.
Yes, sir.
Yes, sir. Yes, sir.
Okay, thank you. Well, let's move on. This another one. Let me quickly pick some things about this one. We may have to spend some time there because it contains some further details. Now, This is Mrs. D, who is 68 years old. This is the history. Single woman live alone. Refer to their patient clinic for a second opinion. Condition deteriorating. Past history of childhood pneumonia and whooping cough. Never smoke. Current issues: bronchiectasis, osteoporosis, gastric esophageal reflux, OAE, chronic sinusitis, non-seasonal. Bronchiectasis diagnosed approximately 20 years ago. Productive cause since a teenager. Respiratory medications: Ventolin, recently commenced azithromycin. Approximately 5 exacerbations requiring antibiotics over the past 12 months. Stress incontinence with coughing and exercise. Appears to be adequately hydrated. Drinks 2 liters of non-caffeinated fluid per day. Exercise limited by shortness of breath and generally feeling unwell. Likes to play golf, but too unwell to play at present. Able to walk approximately 50 meters at a moderate pace before stopping to rest due to shortness of breath. Describes our main issues as excessive sputum and extreme lethargy. St. George Respiratory Questionnaire. Described our health as very poor. Sputum, approximately 1 cup per day. Tenacious and mucopurulent. Nil hemolysis, difficult to expectorate sputum. Isolate Haemophilus influenza. Report that she comes throughout the day, which she finds very tiring and embarrassing. Need previous physiotherapy input, current airway clearance routine, coughing. What is your thought?
She has an ineffective coughing technique, and that is what is driving all our issues. She just needs to be taught effective airway clearance techniques and coping mechanisms, just like the last patient.
Coupled with dyspnea.
Okay.
Another thing is that she has stress incontinence, which is also an indicator.
Let's clap for her. Of all the cases I've presented to you under these practical illustrations, class illustrations, this is the first one we are picking stress incontinence, isn't it?
Yes.
Yes.
Yes, sir.
And this makes it real. What I have told you before, what research shows. Fine, thank you. Now, did you also notice there is comorbidity?
There is comorbidity.
There's comorbidity, isn't it? Now, there is childhood pneumonia, isn't it?
Yes, sir.
Yes, sir.
Which probably suggests, even though it's telling us 20 years ago, if you calculate 20 years ago will be, she was probably 48 years, isn't it? It means that
Yes,
this thing must have started prior to that time, undetected. Isn't it true?
of course. Yes, sir.
Okay, fine. Now, we're able to see also the drug that the patient is using, isn't it? The antibiotics and the bronchodilator.
Yes, sir.
Yes, sir.
That is the Ventolin, the bronchodilator, the antibiotic azithromycin, isn't it?
Yes, sir.
Then we're also able to see the exacerbation now. Our own is 5 in the past 12 months. And then our quality of life has been affected. Even though she can still walk.
Hydrated?
Nothing less than 50 meters tire, isn't it?
Yes, sir.
Now, finally here. No, sorry, 2 things finally here now. I want you to take note of the hemoptysis, 1. I want you to take note of the organism that was isolated, Haemophilus influenza. So when you are doing the scoring, you know how that will affect the scoring of that patient.
Yes, sir.
I hope you pick that. Influenza,
Yes, sir.
Haemophilus influenza is the organism isolated from the sputum.
Yes, sir.
Yes, sir.
Then finally, we also pick up the fact that despite all this comorbidity and the condition of this patient, this woman lives alone. Did you pick that?
Yes, sir.
So we need to attend to all this in the life of this patient. So we move on. These are the further details concerning her. Our SpO2 was 90%. Our FVC1 was 0.88, and then the high resolution computed tomography showed that bronchiectasis right middle lobe, left and right lower dose. That is multiple affectation, isn't it? So on that score, you expect that this patient will be a severe one, isn't it?
Yes, sir.
Yeah.
Severe one. Thank you.
Yes.
So we move on. We move on.
A severe case.
It's a severe case. Now, she had 2 pumps of Ventolin via a spacer. Correct technique was taught her, and then she had nebulized 5% isotonic saline. Let me stop here. You see, this 5% isotonic saline could be used as a mucolytic at times to soften the mucus so that it can easily be expectorated out. Now, the much thing as we round up this patient is that after a week later, when she was reviewed, the patient feel much better. There was less cough, there was much energy. The check meter dose inhaler technique and flutter technique, there was no issues. Then the reviewed autogenic drainage coped better this week. What did we see about physiotherapy intervention?
Effective.
Effective, isn't it?
Very effective in clearing of
Very
air.
effective. Very effective.
Just within a
For
week,
clearing
isn't it?
and
Yes, sir.
Just within a week. Thank you. So we move on. Now, after 6 months, she was okay. The review, the first one was after a week, I've showed us. After 6 months, was reviewed by the physio. And she has returned to her golf after 6 months in a cart, walking daily for 20 to 30 minutes with 2 rests. Is that improvement? Is that improvement?
Yes,
it's an improvement. Thank you.
50 meters.
Yes, thank you. Now, this is a review after additional 6 months. We are not talking after 1 year. The review shows that there was no exacerbation over the past 6 months. That's great, isn't it? She was feeling 100% better. Intervention proven. She was playing 9-hole golf without a cart. You know the distance that has to be covered within 9 holes. Some of you that play golf, you will understand that.
It has improved in endurance to carry out the exercise.
Seriously, improve in endurance. Thank you. You
Nice
are really
hours of
following very well.
walking.
Yes.
No coughing between morning and evening physiotherapy sessions. Sputum production has been reduced, not because he doesn't want to produce, but because it's not there to produce again. Isn't it? Then the sputum volume decreased to half cup per day and not as tenacious and easy to expectorate. Is there improvement or there is no improvement?
Improvement, sir.
Okay, thank you so much.
Improvement, sir.
So this is the presentation that I have for us. I have taken us through a lot of practical examples. I want to leave this slide for you for the next 5 minutes to study. Very important before I now begin to round up our training. Let's look at slide 167. I want you to study it for the next 3 minutes. I will be back with you at 2:32 to discuss with you. Slide 167 is before you. I'll be back at 2:32 to discuss with you. Thank you.
Is it under rationale for physiotherapy strategies?
Yes, and you read this complete slide of 167, the rationale for physiotherapy strategy. You read it, then we'll now come and discuss.
Okay, sir.
Everything on this slide.
Thank you, sir.
Yes. Thank you very much. We are back in class. Are we back? Are we back?
Yes, sir.
Can I ask us questions?
Yes, sir.
Let me start like this. Let me not ask questions. Let me just say what are observations.
I think what the intervention that was provided basically helped to improve our ability to clear our airway effectively and on our own, using autogenic airway clearance techniques. And she also used flutter. Other things that were considered were the use of saline, nebulized saline to help her with it, and the intensity of the the intensity of the technique was actually considered. Instead of coughing because of her urinary incontinence, she was given huffing techniques. I think I saw something about that there. Um, and that also helped her with that. But also automatically everything led to her being able to take up activities of about bug exertion 3 to 4, which is basically like walking. And even with that, that was sufficient for her to have a very good quality of living since her targeted activity was to return to golf. So that was very achievable. In addition to the pacing that they were able to work around her daily schedule.
Thank you so much. Let's clap for him. Good observations. You are flowing. Any other thing? What can you say about the family social history of this person? Social life of this patient?
There was not anything specifically stated except for her distance from the hospital and her participation in the activity, but
Yes, that is
nothing
part
was
of
said.
FSH. It's part of it.
Okay.
It's part of it.
Okay.
If you notice these statements, I hope you are seeing my cursor.
Yes, sir.
Are you seeing my cursor?
Yes, sir.
She was retired, so had time during the day to do her airway clearance. Adherence, isn't it?
Sir, yes, sir.
Yes, sir.
Nobody knows. Probably she didn't have time before to do that.
Now retired. You have time to do it.
He has time to do it, isn't it?
Yes,
Good.
sir.
I'm happy that we picked this. I'm happy we picked this. Any other thing to say before I move on? Now, if you notice, by this presentation, by the time of presentation, look at this statement. She was in a downward spiral. I hope you understand what that statement means.
Downcasted, sir.
Yes, and also the condition was deteriorating.
Yes.
If not for physiotherapy intervention, you wouldn't have jumped into this. Look at this. Look at the flying of this Microsoft. From downward spiral to this exercise of 3 to 4 on box scale. That's significant improvement, isn't it?
Yes, sir.
And I'm also happy that the first speaker got this, the nebulized saline. I told us in what is used before. There was tenacious putu. She was finding it difficult to cough it out, even though there was something there. So it needed to be softened to be coughed down, isn't it?
Exploration.
Pardon?
I said for easy expectoration.
Yes, you are right. Thank you very
Yes,
much. We move on. Now, this is very important for our colleagues in pediatrics. Very important that we go through this, even though I know our time has gone. But let's go through this. I'm going to leave us for another 2 minutes again. So 2:38, I come back. Go through this. Fine, I'm back. I hope you are back. Are we
Yes, sir.
back? It's okay. Thank you so much. I want to appreciate this class. You've been so interactive. You've responded very well in all the questions I've thrown at you. And the mode I've adopted in throwing practical instance to this virtual delivery has actually worked. So I appreciate you for that. And I want you to keep up the lesson you have learned. As you have given these slides, go through it again. The understanding will be deepened. So let me go into discussing this as we begin to round up. What is the age of this patient?
13
What
years
do you
old.
suggest? What does this suggest to you about this presentation of this patient?
Possibly
Infection.
You said what?
Because it combined yellow sputum and vomiting.
Yes.
You can say it's an infection. It's an
Infection
infection.
with rise of temperature, isn't it? Intermittent fever. Intermittent
Yes,
fever,
yes.
isn't it? Now, what did you observe again?
Yes, sir.
She. What else did I say?
Weight loss.
Yeah, no clubbing.
Weight loss. Clap for yourself.
Okay, yes.
Weight loss,
Yeah,
about
the
1
weight
kilogram
loss.
in the past 12 months, 2 months.
Yes,
And vomiting.
And vomiting.
Yes.
Yes, even though it's seldom. And it may be in fact that maybe the cough was with thick sputum.
Vomiting.
Isn't it? It may be.
Yes, sir.
Yes, thank you. Then there's also hemoptysis 15 days back, isn't it?
Yeah, so that's a very strong cough and
Yes,
weak
strong
lung
cough.
tissue.
Pallor, that is cyanosis, reduced hemoglobin. Let's wait. We hope in this instance that there's no complications. I hope you understand. If he has to present with pallor,
yes, sir.
we hope there's no complication that has to be investigated further.
Yes,
that is
sir.
that. But the intriguing thing here is that there is no history of TB.
Yes, sir.
Because the patient received what? BCG vaccine
BCG.
advance. That's a
yes.
plus. You remember that
And
when
no
we are
touch
doing figures on epidemiology, the reason why we have some incidents in Africa was traceable to this, but we can't see this in this child, isn't it?
Yes, sir. Yes, sir.
What else can you see concerning the chest of the patient as we run
the chest expansion,
no respiratory system examination.
the lung, the subcostal retraction, and poor air entry in the lower zones, but the upper zone on the left is okay.
The mini chest movement on the left side.
Thank you.
Yes.
Thank you. And I want you to look at this my cursor and talk.
And dullness on percussion.
Dullness
So
on
that's
percussion.
consolidation, maybe.
So we hope there is no associated pleural effusion here.
Yes, sir.
We hope so. Radiographs will explain that out to us, isn't
especially
it?
with the high pulse rate.
Yes. Now we have a reduced air entry in the left lower zone, isn't it?
Yes, sir.
Yes.
Okay.
Thank you. Thank you very much. We'll begin to round up. Conclusion. Now, bronchiectasis is a chronic respiratory disorder which is associated with reduced quality of life and frequent exacerbation in many patients. It is characterized with cough, breathlessness, sputum production, bronchial infection and reinfection, and is radiologically established through abnormal and permanent dilatation of the bronchi. Then, there are many treatment strategies usually adopted by multidisciplinary team involved in the management of this condition. And treatment available are antibiotics, anti-inflammatories, mucoactive drugs, bronchodilators, surgical treatment, respiratory therapy, which notably chest therapy, airway clearance technique, and endurance exercises. Then the efficacy of physiotherapy intervention in this condition are well documented in literatures. Several outcome measures are available to monitor the progress of the patient. Then the vicious circle of frequent exacerbation actually reduce the quality of life in the affected patient and increase the healthcare cost. The economic burden has been estimated to be similar to that of chronic obstructive pulmonary disease, COPD, and increases with disease severity, hospitalization, and need for intensive care, and the use of inhaled antibiotics. These are the recommendations. There's a need to benchmark quality of care for people with bronchiectasis in our setting to improve outcomes. And then bronchiectasis campaign we need to emphasize patient education, which should be made available in all our hospitals, very important. And like we can see from our training today, from this workshop, standardly equipped, well-staffed, and purpose-trained cardiopulmonary physiotherapy unit to effectively cater for the need of bronchiectasis rehabilitation is very important in our setting. Wish that more resources will be dedicated to procure the equipment that have been highlighted in this workshop, and then personnel will be trained here and there to be able to identify and be able to adequately treat this condition. It's on this note I round up this presentation. These are my references. I give kudos to every one of us that have participated. I will say thank you for enrolling in this engaging bronchiectasis workshop. I look forward to you enrolling in the subsequent workshop that will still be thrown up along this line. So question time before I leave you. Thank you.
Thank you, sir.
Thank you.
So my question here is that for most of this, like for example, severity of bronchiectasis, usually who will be responsible for classifying patients for that? Would that be maybe radiology, medical department, or is that something that must be done within the physiotherapy department?
Thank you very much. From the way that short questionnaire is conditioned, it's like one can extrapolate from the different tests that have been done to arrive at this figure. For one, let me explain myself together again. After you have done all the necessary, well, that is assuming that all the tests have been done. If we assume that all the tests have been done, when those things are on your table at the point of examination, is together and knock them into all those boxes and get those figures out and know the overall figure of the patient. But in instances where those tests have not been done, the patient may have to still now undergo that test after the required professional sent them for that test to do it. But in instances where it's not been done, we can also discuss as part of multidisciplinary team discussion that when we need to get the score of this patient on the bronchopulmonary index. But we can't, bronchiectasis in there, but we can't get it on the this and that. Then the physician would do the necessary referral to get it done. They will now extrapolate the figure. Of course, we are the one that will do the collation if they don't do it on their end.
Yes, sir. Thank you very much, sir. I think it makes a lot of sense because you don't want to stress patients more than is necessary. But if we do the test, at least we know the patient that needs more attention and who does not need as much attention.
Sir, my question, sir.
Yes, go ahead.
If these tests are not, if all these tests are not done by any medical practitioner, are we allowed to do it, or we can ask from doctors that we need this type of test?
You can, like the answer I just gave to the second person. It's a good question you have asked. Let me first of all appreciate that. But like the answer I gave to the last person that asked me question, you can ask because you have the knowledge base. You have been trained. You can say, we need this, I need this, I need this. And I discovered that this has not been done. Then for you, then when the request by you say, I need a copy of the test because it guides me further on what I'm going to do. You can enter into discussion on that.
Thank you, sir.
Yes, sir. Thank you, sir.
Thank you. I want to appreciate the participation of every one of us. I encourage you to keep it up.
My question is.
I thought you had a question.
Yes, sir. So I have a question. Hello, sir.
I've been able to, pardon? I hope I've achieved this.
Yes,
Slide
sir.
3.
Regarding that,
I hope I've achieved
hello,
this slide
sir.
3.
Hello, sir.
Hello, please talk.
Yes,
Go ahead
sir.
and talk.
Regarding that management, you made mention of medications, surgery, and physiotherapy. Sir.
Yes.
So is it that physiotherapy has to come in first, like to see what they can do? After maybe if there is no surgery or the patient has to be classed, is going to surgery or medication will suffice. So that's my question, sir.
It's okay. Thank you very much. What I said is this: failure of or irresponsiveness, that means inability for the patient to respond to medical treatment, will enlist the patient for surgical treatment. Now, but what happened is that after the infection is cleared off, physiotherapy comes in. You remember I talked about combinative therapy. That is using antibiotics and combining it with chest physiotherapy. I told you the therapeutic efficacy of combinative therapy against single therapy. Again, that means when you combine the two together, it has been shown that it's more effective than just have chest therapy alone or having the drug alone. So that is exactly what happened. But you don't quickly rush into surgical intervention until those other procedures have failed. But even after the surgical intervention, I've shown to us now that physiotherapy is still coming. I hope it is clear.
Yes, sir. It's clear, sir. Thank you.
Thank you. I was asking you a question before I leave you. I hope I've achieved this slide 3 for you.
Sir.
In terms of bronchiectasis, I hope I've been able to pick you up.
Yes, sir.
Yes, sir. Very much.
Yeah, very, very well.
Thank you.
Sir,
Thank you.
if the pressure is in place,
You said,
if the infection is still there with the patient, can we do combination therapy?
no, you see, what happened is that it gets to a level that the infection reduces. I hope you understand me. It gets to a level that the infection is dropped to a manageable level. If you see some of those patients that I did case study on, I used to teach you, you discover that infection was still present, isn't it?
Yes, sir.
Yellowish mucopurulent sputum, isn't it?
Yes, sir.
Can you remember?
Oh, yes, sir. Yes, sir.
So at that stage, you can still continue, except where there is serious contraindication. Maybe there is uncontrolled hemoptysis. Maybe there is associated contraindication in cardiac condition, in which it has to be primarily taken care of, then before you now move in. But if there is no those absolute contraindications, you can correctly manage.
Okay, sir. Thank you very much.
Thank you.
Yes, sir.
So I hope slide 3 is achieved as I leave you.
Yes, sir.
So thank you
Yes,
very
sir.
much.
Yes, sir.
Yes, let me hand over to the moderator. Moderator, please, can you take over from me?
Okay, thank you so much for the in-depth presentation. It's highly appreciated, and everyone has enjoyed it. And we thank also the participants for staying all through and participating all through. Thank you so much. Wishing to see you next week. We have another one on congenital heart failure by the same facilitator next week. So wishing to see you and all other participants next week. Thank you all.
Thank you very much, sir.
Thank you.
Yeah,
Bye-bye.
thank you so much, sir.
Happy
Thank you, sir.
weekend.
There's no course that teaches this thing. Thank you, sir.
So bye-bye. Happy weekend.
Hope to see you in Jos by October.
sir. Happy weekend, sir.
Yes, I'll be expecting you in Jos.